Good morning, everyone. My name is Ida Garcia, and I am a Mental Health Foundation Australian Multicultural Ambassador here of South Australia. But a bit of housekeeping. The toilets are located back around the foyer, and hand sanitizer stations are also located in the foyer. And we would like to request everybody to please turn off your mobile phone or probably put it on silent. Lunch will be served after the special dance performance from the Filipino community at 1:15. On behalf of the Mental Health Foundation Australia and our chairperson, Mr. Basan Srinavansan, I would like to welcome and thank each and every one of you for attending our physical and virtual National Symposium on Multicultural Mental Health during the National Health Month 2020. We begin today's proceedings by acknowledging that we are meeting on the traditional country of Ghana, people of the Adelaide Plains, and pay respect to elders and past and present. We recognize and respect their cultural heritage, beliefs, and relationship with the land. We acknowledge that they are of continuing importance to the Ghana people living today. And we also extend that respect to other Aboriginal language groups and other First Nations. The National Mental Health Month is an initiative of the Mental Health Foundation Australia to advocate for and raise awareness of Australian mental health. It is an important time where the Australian community comes together to raise awareness that mental health matters. The Mental Health Foundation's National Mental Health Month is unlike many other mental health awareness campaign. It aims to bring all Australians together to a national conversation about mental health. And we aim to maintain this conversation for an entire month and beyond through a series of various mental health related events. National Mental Health Month is a program that the Mental Health Foundation Australia is extremely proud of, and we intend to reach out to and educate as many Australians as possible to help reduce stigma and facilitate positive and non-judgmental discussion surrounding the important topic of mental health in Australia. With 1 in 5 Australians experiencing a mental health illness, it is time we give health its due attention, and that is exactly what the Mental Health Foundation Australia is wanting to achieve. Throughout the backgrounds to raise awareness of the need for better mental health for all. In today's event, we will engage in a constructive discussion about multicultural mental health in Australia with heads of state and multicultural heads. I would also like to mention the Mental Health Foundation's Multicultural Mental Health Survey. The Mental Health Foundation Australia believes in outcome-based solutions. Hence, we have created a multicultural mental health survey to go out to Australians in the community. The purpose of this survey is to gather information about code communication in Australia and to prepare recommendations to be sent to local, state, and federal levels of government about what is required in this important area of multicultural mental health. You can find the link to the survey on the Mental Health Foundation website or by contacting us at admin.mhfa.org.au. I now invite you to please join us in celebrating the Mental Health Foundation Australia's 90-year journey by viewing a short video.
journey of 1,000 miles begins with a single step. Mental Health Foundation Australia's journey began 90 years ago. It dawned in 1930 with just a founder and vision, which was to reach and impact Victoria. Now we have a presence in all states and changing lives for over 100,000 people throughout Australia. Our organisation's biggest initiative yet is our National Mental Health Month. Our month-long initiative is to advocate and raise awareness on Australian mental health. Our vision is to recharge and educate as many Australians as possible to help reduce stigma and facilitate positive and non-judgmental discussions surrounding the important topic of mental health in Australia. With the theme being Mental Health Matters, the awareness is cumulative. In 30 events we have organised to reach the community in all mental health subject matters affecting our lives today. To further continue our journey of 1,000 miles, the Walk for Mental Health has transitioned from a Victoria-only walk to being a nationwide community walk, where anybody from anywhere in Australia can connect with us and walk with us virtually to spread the impact and awareness of mental health. We pride ourselves with making sure all our programs are for the community and are powered by the community. We have a vast growing network of multicultural ambassadors who are part of our program to further the community voice in promoting positive mental health and wellbeing. Our multicultural network has inspired our educational and multicultural webinars as an initiative to help power Sodality to cope with success during the pandemic, to promote the understanding of unique cultural and ethnic heritage in Australia and the development of culturally responsible and responsive curriculum. The Mental Health Foundation of Australia conducted the multicultural research to continue on the development of the fast-growing multicultural Sodality in Australia. With the effects of COVID-19 pandemic, the MHFA has successfully committed the Power Hour of services and the reach to the community. With the helpline hours extended, we are here to show Australians we can be a shoulder to lean on and can be dialed to assist in all mental health matters. Our impact flows into the COVID-19 meal delivery response with the help of the community, local business and our multicultural ambassadors. It has promoted one vision, which is to serve others before self during this time of uncertainty. With over 45,000 meals delivered, we continue to work with the Department of Health, the Human Services, the Salvation Army and the Australian Multicultural Foundation to continue this success. As we continue to work to deepen understanding the importance of mental well-being and educating the community, let's work together to bring better mental health for all.
I would now like to invite Mr. Helena Chryssopoulos, Director of the Mental Health Foundation in Australia. Helena is the Director of the Mental Health Foundation Australia and the Chief Executive Officer of the Multicultural Communities Council, as an affiliate of the Federation of Ethnic Communities Council of Australia. She previously has worked for Alzheimer's Australia for over 22 years in local government and for not-for-profit in New South Wales. She has over 35 years experience in the multicultural sector and currently sits on multiple boards, including Council of the Aging, Age Rights Advocacy, Service, and the Australia Multicultural Council. Helena, over to you to welcome our distinguished gathering.
Thank you, and good morning, everyone. It's lovely to see everyone here. I'd like to begin by acknowledging the traditional owners of the land on which we meet on today, the Kaurna people, and pay my respects to elders past and present. On behalf of the Mental Health Foundation Australia and our chairperson, Mr. Basan Srinivasan, I would like to welcome and thank each and every one of you for attending today's National Symposium on Multicultural Communities, Mental Health and Wellbeing, organised as part of the National Mental Health Month Awareness Campaign. Thank you to those of you who are joining us via Zoom and Facebook Live, so the cameras are working in the back there. National Mental Health Month is an initiative of the Mental Health Foundation Australia to advocate for and raise awareness of Australian mental health. It is an important time where the Australian community comes together to raise awareness that mental health matters. Throughout this month, many events have been organised in each state and territory of Australia, aiming to attract and unite Australians of all ages and backgrounds to raise awareness of the need for better mental health for all. As part of the busy month, the Mental Health Foundation has run a set of conferences in each state and territory on one of the issues in relation to mental health. And in South Australia, we have the National Symposium on Multicultural Health, Communities, Mental Health and Wellbeing. This symposium aims to discuss the issues surrounding multicultural communities' mental health, what services are available for them, what can be done to better these services, and how these issues can be minimised in the future. The symposium will be an excellent avenue to raise concerns and bring to the attention of many key figures, including heads of organisations in the area of multicultural mental health in South Australia, members of Parliament, mental health officials, of what is required to bridge the gap in services. The purposes of this major event is to collate all the concerns raised and prepare a list of recommendations to be sent to all levels of government, both locally and federally, so they can take the necessary actions to combat the issues of multicultural mental health in Australia. I would like to welcome all our dignitaries here today and all of you who have chosen to be here present. The Lord Mayor of Adelaide, Sandy Verschoor, thank you for joining us. The Honourable Stephen Wade, MLC Minister for Health, will have a presentation with him as well. The Honourable Jing Lee, Liberal MLC and Assistant Minister to the Premier. Mr Chris Picton, who's running a few minutes late. Hello. The Shadow Minister for Health and Wellbeing, you snuck in. Associate Professor Lillian Mawani, College of Medicine and Public Health, Flinders University. Good morning. And we're going to be hearing from the adjunct Professor Harry Manas. Some of you would know Harry. Harry has a very long involvement in mental health, both locally and nationally and also internationally, I believe, as well. He's the head of Global Cultural Mental Health Unit, Centre for Mental Health, Melbourne School of Population Global Health. Nancy Huang, who is the Chief Medical Advisor for Australian Unity. Dr. John Brayley, who's joining us personally, the Chief Psychiatrist of South Australia. Inam Udi, a good friend of mine, and we've worked for many years together, Relationships Australia. Zakira Mohammed, Manager of Health and Family Safety Program, the Australian Refugee Association. And also, not last but not least, Professor Nicholas Proctor, Chair of Mental Health Nursing and Leader of the Mental Health Suicide Prevention Research Group of the University of South Australia. Could you all please give them a warm welcome? And I look forward to this morning presentations, and over to you, Ida. Thank you.
Thank you, Helena. It is my great pleasure now to invite the Lord Mayor, Sandy Verschoor, City of Adelaide, for her welcome address. Sandy is the first generation of a Dutch, French, Portuguese, and Ceylonese descent. Her parents gave her a deep-rooted understanding of business, an adventurous spirit, commercial acumen, and a love of the arts. Sandy was elected as a City of Adelaide Area Councillor in the 2015 by-election and served as Deputy Lord Mayor from June 2017 to November 2018. She has had a career, both the public and private enterprise, not-for-profit, and local and state government. Elected Lord Mayor in November 2018, Sandy is keen to keep costs low for residents and businesses by reducing red tape, strengthening Adelaide's global reputation for culture, climate change action, and entrepreneurialism. the preserving Adelaide's heritage and enhancing the city's precincts and main streets for the benefit of local, small business owner and the community. Ladies and gentlemen, please welcome the Right Honorable Sandy Verscher, Lord Mayor of Adelaide.
Manina Pudni, Nadlu Tampandi, Nadlu Ghana, Yatanga Takandi. In the language of the Ghana people, I welcome you all and acknowledge their own traditional country of the Ghana people of the Adelaide Plains and pay my respects to elders past, present and emerging. And we recognise and respect their cultural heritage, beliefs and relationship with this beautiful land. Distinguished guests, Multicultural Association and community leaders, esteemed medical professionals who are gathered here today, ladies and gentlemen. I'm very happy to be here today to discuss such an important issue during National Mental Health Month. It's particularly significant at the moment when people have been doing it so tough as a result of the COVID-19 pandemic. In addition to the physical health risks, the prolonged and ongoing restrictions on travel, the loss of social connection and the virus's impact on the economy are all taking a toll on people's mental health. This is particularly true for our migrant and multicultural communities who may be separated from loved ones or have even lost family members overseas or are now feeling fearful and alone. My own daughter-in-law is in daily contact with her family in Colombia. And there's very high levels of anxiety in our family. The City of Adelaide's role in addressing this is primarily in supporting social connection and promoting positive mental wellbeing. While providing mental health services are not a core function of the Council has a strong focus on the health and wellbeing of our community. This is recognised in the South Australian Public Health Act 2011, which encourages councils to work towards minimising the risk of chronic disease and promoting health and wellbeing. The City of Adelaide delivers many community-based programs and activities that seek to improve people's mental well-being. And these are things such as community shared meals, lifelong learning programs at the library, healthy ageing exercise groups, and volunteering. We have a city wellbeing team that have a particular focus on supporting our international students, with many of those students living in the city. And the City of Adelaide is a key funding partner of Study Adelaide and works closely to develop programs and share information, including setting up a web page during the COVID-19 lockdown and supporting the creation of a wellbeing series that is currently being delivered online. Excuse me, I do have hay fever. So over the last few years, we have developed a partnership with Headspace Adelaide, and in 2019, we jointly held a forum for over 40 international students, accommodation and support services providers. This enabled support services to have a better understanding of what is available for international students to support their mental health. This ongoing partnership with Headspace has included a recent event called Stretch Yourself, which enabled Headspace youth ambassadors to provide a workshop for international students, followed by a joint tree climb experience in our beautiful parklands. We hope to replicate this over the coming summer season, when we know that many of our vulnerable international students will remain in Adelaide as they're unable to return home due to the border restrictions. We obviously hold concerns for the mental health and wellbeing of these young people and are working hard to ensure opportunities for social connection and engagement. As a result, we're part of the Study Adelaide Task Force recently established to look at this very issue. And the City of Adelaide also ensures that international students and people from multicultural backgrounds are considered more broadly within programs within our libraries and also our community centres. The City of Adelaide's community centres provide ESL classes for all learning levels across families, as well as at the Hutt Street Library. We also have a number of local people teaching native language to others, and this ranges from French and Spanish to Arabic and Mandarin. Mental Health Week activities, including those run by Mental Health Coalition of South Australia, have been supported by community development grant funding, and events and activities have taken place in our community centres for the past 6 years. We also provided funding and locations for the Positive Signs project, which was the brainchild of entrepreneur Reese Formosa and resulted in uplifting murals being created by artist Matthew Stuckey in our Pewey and Rundle Street car parks. In addition, we worked closely with Multicultural Communities SA and hosted workshops and leadership forums. We've built strong relationships with the Adelaide Mosque and their local community over a number of years, including hosting the iftar breakfast during Ramadan at the Adelaide Southwest Community Centre. And we supported the mosque to host the first ever Community Open Day last year in 2019. Council proudly declared Adelaide as a refugee welcome zone in 2014 and officially became a refugee welcome zone in 2017. And we were the first capital city in Australia to do so. We also joined the Welcoming Cities Network in 2018. The City of Adelaide is proud to be a diverse, inclusive and welcoming city, and we're uniquely designed as a city in the park with 760 hectares of natural and cultural landscapes. And I do encourage you to spend time there with your families and look after yourself in that beautiful landscape. As a city, we'll continue to do everything we can to support our communities through this challenging time. And I welcome today's speakers and wish you all a productive symposium. Thank you.
Thank you, Lord Mayor Bischoff, for your support towards this year's National Mental Health Month Awareness Campaign, and it is greatly appreciated. I would like to call on Ms. Helena to present the engraved pen as a gesture of appreciation. Okay. Nice and quiet. I would like to take this opportunity now to welcome the Honorable Stephen Wade, member of the Legislative Council, for an official launch of the Multicultural Communities Mental Health and Wellbeing Symposium. As Minister for Health and Wellbeing, Stephen Wade's portfolio covers health, well-being, mental health, aging well, substance abuse, and suicide prevention. After graduating in law and economics from the University of Adelaide, he worked as a parliamentary advisor at state and federal level, including for former Liberal Health Minister, Dr. Michael Armitage. The minister has also worked in corporate governance and on a range of boards. He was appointed to the Legislative Council in 2006 and served as a shadow minister in a range of portfolios from April 2007. He was appointed Minister for Health in March 2018. Ladies and gentlemen, please join me in welcoming the Honorable Stephen Wade in his recorded video message.
Good morning. I'd like to acknowledge the Honourable Jing Lee, MLC, Assistant Minister to the Premier, Mr. Peter Malinauskas, MP, Leader of the Opposition, Mr. Chris Picton, MP, Shadow Minister for Health and Wellbeing. From the Mental Health Foundation of Australia, Mr. Vasan Srinivasan, the Chairperson, Mr. Jim Gooden, Vice Chair, and Ms. Helen Kyriopoulos, Director. I'd also like to acknowledge Ms. Sandy Bashaw, the Lord Mayor of Adelaide, Dr. John Braley, the Chief Psychiatrist, Associate Professor Harry Minnis from the Centre for Mental Health at the University of Melbourne, Professor Nicholas Proctor from the Mental Health and Suicide Prevention Research Group at the University of South Australia, Nancy Hwang from Australian Unity, Associate Professor Lillian Moorani from the College of Medicine and Public Health, Flinders University, Inam Udi, Relationships Australia, South Australia, Zakay Mohammed from the Australian Refugee Association. I acknowledge that the land we meet on today is the traditional lands of the Kaurna people and pay my respects to their elders, past, present and future. The Government of South Australia acknowledges the important work that the Mental Health Foundation Australia does in raising awareness, promoting positive community engagement in the area of mental health and wellbeing, and providing a platform for collaborative change in partnership with governments, organisations and the community. I note in particular the role that the Mental Health Foundation plays in promoting mental health and wellbeing of the multicultural community in Australia and your actions in this area. The Foundation directs and assists fellow multicultural ambassadors to reach out to communities and promote and campaign for better mental health for all. I note the association has 12 community ambassadors in South Australia, and it will be interesting to hear about their community engagement work here. The Mental Health Foundation has a commitment to working collaboratively with multicultural communities and better educating the general community on general and specific multicultural communities' mental health needs. The South Australian Government has a strong commitment to promoting positive mental health and wellbeing in the community and values working in partnerships with a range of non-government organisations, including the MHFA, to continue to improve mental health and wellbeing outcomes across the entire population. The Mental Health Services Plan 2020 to 25 acknowledges the cultural needs of migrants, refugees, asylum seekers and international students in South Australia. We know that equitable access to mental health services is a significant issue for people from culturally and linguistically diverse backgrounds. The plan aims to ensure all people and communities have timely access to mental health care that is shaped around their diverse needs and preferences, whilst taking into account the health and social needs at all stages of the life course. The plan aims to ensure all care delivered will be based on trauma-informed care and encourages partnerships with multicultural services to improve access and engagement for people from culturally diverse backgrounds, including the use of accredited interpreters and cultural liaison staff. In the context of the plan, SA Health has commissioned STARS to continue providing support to asylum seekers, refugees and other migrants in South Australia who have their mental health impacted by torture or trauma, as well as supporting mental health practitioners from acute and community settings to develop skills to provide a culturally responsive mental health service. The plan intends to scope an anti-stigma initiative to specifically target stigma and discrimination experienced by those who are known to face inequality in service access across health services. We know that stigma can be a major issue for people from culturally and linguistically diverse backgrounds. During the life of the plan, there is an intention to develop a cultural peer service to support mental health service delivery to older people from CALD communities. Throughout the COVID-19 period, SA Health has provided funding and worked in partnership with Relationships Australia to deliver support services to multicultural communities as part of the SA COVID-19 mental health response. In consultation with Relationships Australia and based on the emerging needs in the community, it has been particularly evident that the pandemic is having a significant impact on the mental health and wellbeing of multicultural communities. SA Health acknowledges that this challenge requires a targeted approach, focusing on service and community engagement, access to information about the mental health impacts of COVID-19, encouraging help seeking and ensuring that services are accessible and equipped to provide culturally appropriate care. Through reports from this service, it is clear that CALD communities have not only had to face the impact of COVID in Australia, but also at times the greater impact in their countries of origin as they have received news from family members without being able to be there to offer support. COVID-19 has brought our communities together in fresh ways. It's reminded us again that for each of us to be healthy, we need to protect the health of all. Whether it's protecting our communities from the spread of the virus, or whether it's building community connectedness to protect mental health and wellbeing, we are all in this together. In this special context, I am pleased to open this National Symposium on Multicultural Mental Health. Thank you.
Thank you, Minister Wade, for your support towards this year's National Mental Health Month Awareness Campaign. As a thank you gesture, a small token of our appreciation will be posted to you. I would now like to invite the Honorable Jing Lee to formally address the gathering. The Honorable Jing Lee, member of the Legislative Council, is the Assistant Minister to the Premier, the Honorable Stephen Marshall, member of the Legislative Council in the South Australian Parliament. 2020 marks 10 years since Jing made history for changing the political landscape of South Australia as the first Malaysian migrant with Chinese heritage to be elected to state parliament in 2010. Jing is a proud Australian and is deeply honored to have become the first Asian migrant to be appointed as the Assistant Minister to the Premier of South Australia under the Marshall government in April 2018. Jing plays a significant role in building community capacity through active community engagement and policy development, and seeks every opportunity to serve all members of our community. With portfolio responsibility for multicultural affairs, Jing is passionate about encouraging interculturalism and delivering better outcomes and integrated services to support an inclusive and vibrant community. Please join me in welcoming the Honorable Jing Lee on stage for a formal address.
A very good morning to everyone. Now, I deliberately wear some bright colors and I didn't realize that my particular outfit actually matched all the chairs. This is a very important symposium. Can I also acknowledge the distinguished guests, community leaders, professionals, medical professionals joining us this morning. Mental health does matters. And to go after the speech after Minister Wade is a lot easier because he already outlined our government commitment, the South Australian government commitment to health and wellbeing, and also put the attention on what we're doing for mental health services for CULT communities. But I want to touch on some personal experience and the work that and my admiration for so many community groups, including MCCSA, of course, AMRC and ARA and other community groups, associations. There are over 1,000 multicultural organisations in South Australia. So when COVID hit the ground in South Australia, there were many, many events, what we call events grants, which is part of Department and Premier's Cabinet grants. I look at those grants and know that events is not going to happen. I spoke to Minister Michelle Lansing because the Department of Human Services also have grants for events. Straight away, we converted those grants, those community grants, into COVID outreach program. In order to then, I also pick up the phone straight away and met with the Honourable Stephen Wade, Minister for Health, and also the Premier call for meetings immediately with community peak bodies. And we converted the resources immediately into translated materials about COVID information and got the information out there. Now, it is not an accident. It's not an accident that South Australia is one of the safest places on earth. We have so much to thank for. And when you look at the cases in interstate, when ABC, SBS News and all the major news channels starting to print about the problems, the community transmission in COVID in other states, did it happen in South Australia? Largely no. Every time we had an outbreak, whether it's at Dapperton School, Professor Nicholas Spiro and SA Health team was able to get into it straight away. But that is not because it's just on the health element and support. It was direct contact with a community organization, with community leaders. They pick up the phone, call the parents, and ask the students to go into isolation. Some didn't understand what it was. They're concerned about isolation, the kids not getting supported. We have MISA, providing a helpline 24/7, SMS helpline, how kids like to do everything on their phone. So we were able to tailor those solutions to assist people in isolation, helping the community groups overcoming those anxiety, the stress level, having somebody at the end of the phone able to speak their lingo is so important. It's just not the language issue, it's actually the whole pastoral spiritual support that goes with it as well. I spotted Kathy Chong over there. Kathy also run a COVID program for the Chinese and also Asian community, Malaysian, Singaporean communities that may be facing COVID anxiety. Mental health matters. Sometimes you think people that are strong and often are not the strongest. Mental health is a bit like coronavirus. It's invisible. You actually can't see it until you sit down and maybe have a chat. So for everyone in this room, I believe you have been reaching out to your community members, friends, family, to give them the support. Every little bit of kindness, every little bit of advice do help the person that maybe, just maybe, by you asking, are you okay? Make things okay again, even though they're not, going through some traumatic times. Cold communities, because of language issues or distance away from family, concerning about jobs, managing business, they may, have the downturn in running small business. Many of the cultural, linguistically diverse communities are, from all walks of life, and they are affected. I've recently lost two friends. One of them, I thought, there's no way he could have put himself through this. None of us understood it. His family didn't. A 43 years old Malaysian Chinese doctor took his life. A few days before Father's Day, he left behind his beautiful wife and 3 children. I moved 2 condolence. I spoke about 2 condolence sort of motion in Parliament. One was the victim of a friend's father, the first COVID victim in South Australia. And I spoke about her father in Parliament. And the other one, it was like a eulogy I have to deliver in Parliament, was about Dr. Yun Yap, a very successful doctor, 43 years old. He had everything going for him. He was first in his class for everything. He received a scholarship to do the Cambridge A-level, which is equivalent to matriculation when he was in Malaysia. He received full scholarship to study medicine in Adelaide University. So that kind of highlight the caliber of a person he was. but what made him left home 10 a.m. in the morning, didn't tell his family where he was going, and they found his body the next day where he took his life. So you think about the pressures, so it doesn't matter what status, what religion, what, national background or multicultural background you are in, mental health does not discriminate, unfortunately. So I want you to take this moment and whatever you learn from this symposium, the research materials, to come back to inform our government and local government and federal government what needs to be done, what we can do better to improve the health and well-being of our culturally and linguistically diverse communities. Because if one person gets stronger, their family got stronger, and the community becomes stronger as a whole. I went through some terrible times recently as well. I want to just very quickly touch on that. My name was dragged through mud for the first time in my life. And for the first time, I'm pretty resilient. And for the first time, I felt I had mental health issues. I felt, okay, I'm just going to describe this. I felt that I was still alive, but I was locked inside a coffin. They were going to bury me alive, and I felt it inside. I couldn't breathe. I felt that the coffin is going into the ground. I can see sands and soil being put on me. I tried to push the coffin open, but I couldn't. This smear campaign certainly took a little bit of toll, but you know what? You got to reach out to your, find that the most powerful person in your life and call out to that person. I did. I said, Mom, can you my mom is no longer with us, so she's watching us from above. So I said, Mom, can you just help me out a little bit, because I'm pretty strong, but I need a little bit of help. I heard her voice and she said, my little girl, when you were young, every time when there's a storm coming and there's rain clouds, you always say, hey, let the rain clouds come down on earth and to be my doona. So he said, you can handle anything in your life because you've been strong as a little girl. So you can do this again. Just show people what you are made of. And that moment, suddenly she gave me a magic finger, and I did push the coffin board out. I got out from the coffin, I dusted myself off, and I stood up again and say, hey, I can do this. So every person that you know, even if they might look strong and they have status, career status and in position of power, it doesn't matter where they come from. There will be moments that you have a bit of weaknesses. You do need to find that strength. And that, for me, that was calling out to the most powerful person in my life. And that was my mother. And I want to use this story, personal story, to perhaps share with all the community members and people, in your life, is that let's talk mental health. Let's speak up. Let's not let this disease to be invisible. Anybody can get over it, but some will need that little bit of help, whether it is from a professional help or through your friends and through community leaders. But let us work together. Let us all be the strength for another person. Thank you very much for having me today.
Thank you, Honorable Jingli, for your support towards this year's National Mental Health Month awareness, and especially in sharing your story with us, because I'm sure each and every one of us have gone through it one way or another. I have. Anyway, it is greatly appreciated, and I would like to invite Ms. Helena Kyriakopoulos again on stage to present an engraved pen as a gesture of appreciation. I would now like to invite Mr. Chris Picton for his formal address. Chris is the Shadow Minister for Health and Wellbeing and a member of Ghana covering the outer southern suburbs of Adelaide. In the former state Labour government, Chris served as Minister for Police, Emergency Service and Correctional Services after a period as Parliamentary Secretary to the Treasurer. He previously has served as Chief of Staff and Senior Advisor to Federal and South Australian Health Minister, as well as an Associate Director at Deloitte Access Economics. Please join me in welcoming Mr. Chris Picton.
Well, thank you very much for the introduction, and thank you for having me here today. Acknowledge all the VIPs that we have here, the Lord Mayor, Ms. Lee, Dr. Brayley, Professor Proctor, and all the other key VIPs, but particularly all the clinicians, all the members of the multicultural community in South Australia that we have here, everybody on Zoom in very 2020 way who will be streaming in and watching. The mere fact that we can even have people meeting in person this year in a conference in South Australia is a testament to how well our state has done in managing the virus, and everybody deserves credit from that, from the leadership from Professor Spurrier on down, the government who's listened to her, but particularly the community who's taken on board the advice and acted on all of the recommendations in South Australia. And a huge amount of credit for that, as Jing was suggesting, does go to the multicultural communities in South Australia who have listened to the advice, have heeded that advice and disseminated information amongst their communities to make sure that everybody can stay healthy from the virus. Of course, even having said that though, when we're talking about mental health, we are not immune from the issues in mental health that I think are being seen around the world in terms of the exacerbation of those issues because of the COVID-19 pandemic. When this conference was initially planned back in March, I mean, these were big enough issues even then in terms of the mental health impacts in multicultural communities. Of course, March had to be cancelled and deferred to now, given what happened. And now, in this point in time, those issues are even greater. And this conference is therefore even more important than it was back then. There's a number of reasons why the issues for multicultural communities are even greater. Clearly, there are issues for the entire community around isolation, but they have only been exacerbated for multicultural communities. So obviously, by definition, those multicultural communities are going to have more connection around the world, more connection even around Australia. And seeing loved ones has been obviously difficult, if not impossible, for many people around the world. And to be in a situation where if you had a birth of a grandchild or a dying relative or some other significant event that you had to be there, usually it would be a matter of raising the money to fly somewhere to be there. That has been impossible for so many people this year. And it's also meant a lot of people are more isolated, which only increases the risk. We also know that there's a huge need for community connection, and the number of the thousands of different groups that we have across South Australia and Australia who provide that community connection. Those events, the work that those multicultural groups do in South Australia and Australia have obviously been limited in terms of their ability to outreach, to make connections, to bring communities together. That has clearly been an issue as well. Obviously, there's been significant economic impacts from the pandemic as well. And we are feeling that here in South Australia with increased unemployment. And multicultural communities do wear the brunt of that, particularly in lots of industries where there'll be casualised work and other more insecure work that has been impacted, as well as other people who have small businesses that have been impacted and suffering the stress and anxiety from that. And clearly there are mental health effects there. And obviously we've also had this awful situation for many international students who have been stranded in Australia, been unable to access a whole range of different welfare programs that other people in the community have been able to access. And there clearly hasn't been the support available for them that there has been for other people, to the extent that we've seen long lineups of international students waiting in line for food outside of charities here in South Australia and across the country as well. Unfortunately, all of this is leading to increased demand, increased risks of mental health across the community. We are seeing hospitalisations of people for mental health illnesses going up. We have seen demand on community services going up, and just the other week was at Headspace in Adelaide, and they've seen a big increase in their demand for services for youth mental health, that they have a long waiting list, can't keep up with that demand. And particularly they've been helping a number of those international students who've been stranded as well in the CBD. And we're also, unfortunately, seeing the impact on suicide as well. And last week we had the official statistics of deaths in Australia released, and they were only the 2019 deaths, but they did show already in 2019 that the suicide rate, sadly, in South Australia and Australia was going up, not down. So there's already an issue, let alone all the 2020 issues on top of that we have to deal with. And we do see, unfortunately, here in South Australia, that there isn't the significant amount of money that's being spent in other states on additional COVID-19 mental health support and packages. In other states, there's been tens and tens of millions of dollars spent on mental health effects of COVID. We haven't seen that here. And some of the stimulus has been at a lower rate in terms of the economic effects as well. However, given that situation, there is obviously the opportunity to do more. There is the opportunity to make sure that we can address this. And that's why this conference is so important. And I hope that the government representatives can go back to the minister who was unable to attend and put forward a range of ideas coming out of today on how we can improve the situation, because we do know that the mental health effects are going to be a lot longer lasting. Obviously, I think at least COVID is going to be here for a significant amount of time to come. Donald Trump thinks it's all going to disappear overnight, but I don't think that's necessarily true. But we do know that there will be a longer period of time in which we will be dealing with the mental health effects of COVID. So I hope that we can get some good recommendations out of today. I mean, I think just to mention a few of those things that I hope we can get some ideas and discussion about. Clearly, we should be looking at what economic help there can be for multicultural communities, whether they be international students, refugees, or other communities that have been particularly impacted by the economic impacts of the recession. I hope that we can talk about how we can improve the work with multicultural groups and the communities to make sure that those groups have the information, have the resources that they need to reach out to members of their community to help on mental health matters. I hope we can improve, obviously there was mentioned by Ms. Lee before about translation, but I hope we can improve even more information that we are having translated and available in different languages, not just in written form, but in verbal form as well. I know my wife is Italian. Her nonna never learnt to read even Italian. You know, just giving her something written in Italian isn't necessarily going to help her. We need to think of other forms of getting that information out as well. We need to provide additional help for community services. We need to make sure that all of those providers, you know, the headspaces, but also all of those other community providers have the support that they need, have the resources that they need to help in the community, and that if it comes to it, that our hospitals have the resources that they need as well for what they're seeing as an increase in demand. But last but not least, I hope that we are listening to you, that we are making sure that you're involved in the conversation, you're involved in the decision making, because ultimately that is going to be how we get good outcomes to come out of this and make sure that we are as best prepared in terms of managing the long-term effects of the pandemic on mental health services. So thank you very much for having me today, and I hope there's some great outcomes of this conference, and I look forward to hearing about them. Thank you.
Thank you, Mr. Chris Picton, for your support to this year's National Mental Health Awareness Campaign. I would like to call on Dharuv Kumar to please present an engraved pen as a gesture of appreciation. I would now like to invite our first speaker and guest of honor, Associate Professor Dr. Lilian Mwani. Associate Professor Dr. Lilian Mwani was born in Tanzania, East Africa, and graduated in medicine from the University of Dar es Salaam in 1991. She held senior positions in both clinical and public health medicine in Tanzania before migrating to Australia in 1998. In Australia, Lilian has worked in a wide range of settings such as governments, communities, and in academia. Lilian has a Master of Community Nutrition, a degree from the University of Queensland, and PhD from the University of Adelaide. She is also a Fellow of the Australasian Faculty of Public Health Medicine, the Royal Australasian College of Physicians. As a public health physician, she has gained a vast and extensive experience in a wide range of issues and public health, including health promotion, epidemiology, ethics, chronic disease, mental health, community engagement, and community development. She has worked with many migrants, especially Africans in Australia, to address a wide range of health issues. Her experience and interest in migration and public health medicine has seen her conducting research activity in healthy aging, physical activity and mental health, HIV, and other chronic disease in culturally and linguistically diverse populations. She collaborates with many migrants communities and organizations across Australia and has worked in the government institutions including SA Health. She is currently working in public health practice and academia at the Flinders University of South Australia. She has significant roles in teaching high degree by research and supervision research in public health medicine. Lilian has over 120 academic publications, mainly in cold populations and global health. During the last 15 years, she has focused her research in cold populations, including issues related to aging, chronic conditions, and mental health, especially of young people. She currently serves on several advisory groups. She is an editor of the International Journals in Public Health and has presented in many local and international conferences. Her main research interests currently include cold population general issues, social and health inequality and equities research that makes a difference in improving policy, practice, and service delivery, especially for cold migrants and refugees in Australia, as well as global health. Ladies and gentlemen, please join me in welcoming Associate Professor Dr. Lilian Moani.
Thank you very much, Ida, for that introduction, and hello, everybody. And it's really hard to talk after the minister and the shadow minister have talked, because they have summarized almost everything which I wanted to talk. But there's a lot, and I think I've been given just a short time to speak, and I wanted to even have an hour to speak, because I'm going to speak from my own experiences, but more importantly, from my research. As you heard from this introduction, I have been working with migrants for a long time, and that Flinders has given me a platform to talk to communities more, and also to gain a lot of evidence from the communities to see what are the issues. I work across many social issues, but mental health is one of those issues which is really important. And I agree very, very well with the Minister Jingli, because mental health is really matters not only for people who are affected, but for everybody. So it must be everybody's business. So to start with this, I would like to acknowledge that we are in the land of Ghana people, and I respect the elders, past, present, and the future. So thank you very much. And just to start, this slide, I wanted to just highlight the diversity of multicultural people who you know very well. And according to the ABC, according to the census in 2016, the Australian population, we reached the 23 million. But of these, almost 50% or 49% were people who were born overseas, first generation, or a person would have one parent or more, or two parents who were born overseas. So it's a significant number of people, population, who were born overseas. And therefore, when we speak of multicultural communities, we speak of people who are a significant proportion of the Australian, almost 50%. And according to this census, almost over 27% of the population spoke a language more than English in their homes. So it's a big population, and it's so diverse, and the diversity is so broad, such that talking about mental health is not something very easy, something which is very difficult because of the diversity which we are, and therefore having policies or services, it's very difficult because you cannot really address equity and give everybody the equity or the services which will fit their needs. So this particular slide is about the generation which I talked about. And from the ABC, again, we can see that the first generation of Australian is almost 29%, and the second 28%, and the second generation about 21%. So significant number of people who were born overseas, and therefore significant of migrants or community proportion, which is from migration. And when we looked at where these people live, really we see that they live across the country. And when we talk about South Australia, we see that almost a quarter of us are from migrant populations. So 25% of South Australian coming from migrant populations. So this is just a highlight, a really broad highlight of where these people come from. And my experiences are from people who have come recently, just myself, and just 20 years or less than 20 years. And in the first slide, I don't know how this works. Do we have the pointer? Does it have a pointer? No, oops, no, it is. Yeah, so the first photograph on the left, top left, is a place whereby some of the migrants, particularly Africans, have come from recent times. So it's a very poor village, farming village, where people have come and they may not even know how to speak English or even their language. They don't speak or read their own languages, similar to what Mr. Picton told us, that his mother-in-law is from Italian, and she's been here for a long time. I reads no, not even from her own language. The second part where is that it's a person or people who come from Afghanistan. Other people may come from areas such as slums in Nairobi, where it's very congested, or some people may come, just someone like me who come from urban. So the journey of migration is very complex with the diversity, which I talked about before, and very complex in providing mental health services. So post-migration, when people come here, they have been bombarded with a lot of things. They have to cope with pressures of accommodation, looking at what they can do to fit. Finances are normally very scarce, and therefore you can imagine if people are already disadvantaged, because people who have come, like I've talked, they're already at the backbench because of the disadvantages which they've come with. And therefore settling and having such pressures is very confronting. But luckily in Australia, we have a lot of support. Centrelink is very supportive. We have all other migrant services which have been supportive, but these are not really adequate to curb the impact of mental health and other social issues which affect migrants or cultural migrants. So the settlement journey, as I said, is very complex. And because people have come with disadvantages already, they are at the back seat of addressing these issues. So the experiences differ from where people come from, as well as the circumstances which people have brought, or the circumstances which have brought people to here. So people may have lots of confronting issues. Some of these issues could be the cultural perspectives where people have come from, the different cultures, so they have to adjust and learn how to live in Australia. They may have customs or some of the faith issues which may be confronting to change and fit in the situation. They may also have some other issues, and the history which I talked about may also be very important in the way they settle here and address issues and living comfortably, to talk about healthy living. And when we come here, particularly, the health services are fit to the situation whereby they've been developed for many years. So having to address some of the issues which I mentioned could be very confronting, not only for the migrants themselves, but also for the health system. So again, people who come from the places where I talked about, they are very communal. So in the setting where they come from, the original place, they have the network, and the community is very communal. So when they come here, they have lost that community, they've lost the networks, and that complexes, or they make the mental health very complex issue. And surrounding environment is very different, and therefore really compounding the complexity. So as I said, in the past 5 years, I have been researching migrant health, and particularly the mental health. And we do that through literature, we do through really first or primary data collection. And lots of issues have been revealed to us, which we are using to advocate for services, and also for to provide evidence so that policies and other things can be evidence-based policies. So in the recent literature review, which was conducted among Western countries, provided a lot of information about the experiences of people, particularly migrants, new migrants, and refugees. And it says that in the community, the migrants and refugees have got more predisposition to mental health, and up to 10% of migrants would have mental health compared to people who have not had exposure of migration. It also says that men are almost 6 times higher likely to develop psychosocial stress, because they are also more vulnerable to these situations. And this same literature tells us that people who have come from these areas, which I said before, they have other vulnerabilities because they may not have access to services such as immunization, health promotion, and the like, which somehow helps to address not only whole total health, but also mental health. So as you can see, then the migrants, and particularly newer migrants, have got a lot of issues which set them at the back. And when we talk about mental health for the population, we have to think of this population as really vulnerable and a special population which needs to be given a little bit of weight in addressing. So these are my own research findings which we've done over the past 10 years from Flinders. And when we talk about refugees particularly, their experiences of migration from the time when they fly from their home countries, particularly if they had been in the flight because of civil war or civil unrest, then they have these traumatic events which have happened to them. And this trauma often continues during pre-migration and also during post-migration. And therefore, they continue to have this low level of mental health, which is very important to realize and to understand, because the dynamics and the things which happen within people, it's very important to see that they have been addressed in order for them to really live a very healthy life. And I may say as well that when we talk about these issues, in particularly something like this conference, it will be unfair to talk without really projecting the voices of migrants and those who have been the victims of mental health. And these vignettes which I've copied here are some of the findings which I just copied from my databases of information or evidence we've got from the communities. And these particular ones were from the findings of people who were over 18 years old, and they were from the multicultural communities in Australia. And we were asking we were asking people of different experiences of mental health. In particular, this slide provides some information when we are looking at the increased suicide in the community. In a particular community, we had a rise of suicide tendencies. People were attempting suicides, and there are also some completion suicide cases in this community. So when we ask people their experiences, we had really a lot of revelations. And these ones, they talk to themselves. So I may read just a few to see that how people feel when we don't know, because when we talk here, when we haven't got this projection of their voices, it's not very easy to know. But this particular young man say, am I happy? I can say I am, but like in the sense, I really don't know, because everything looks very good. I'm not really happy. Like back home, I was happy. Like we had no food and this stuff, but I was still happy. It's just the, maybe you can think about that. You've been just not happy because you are surrounded by a fence around you and you just want to escape. You have no way to escape. Do you know what I mean? So those are the things which really people have in their hearts, and we may not know until when we talk to people. So when we were in Africa, this was someone from Africa, life was really, really, really terrible. And when I come here, I thought, personally, I'll be happy. But really, every day when I wake up in the morning, the only thing I see shining is the sun, but my life is not shining. So this is a young person who is saying that, well, there is a shine here, there's food, there's anything, but there's no way I'm happy within this. So these are little things which happen in people's lives, and without knowing them, we cannot really develop some of the services which we have developed. So this one is from the a group which is much older, and they were talking about the health services, the way people access services, and also the way they understand. Some of these were elders as well. So like those discussions are like taboo in the community. They are like a topic like mental health or gambling or domestic violence. These are discussions really we don't talk about. And if we know them, we really hide them because it's not something which we want to talk. So people don't necessarily talk about mental health because in some cultures, it's very bad to talk about it and it's taboo. And therefore people don't necessarily talk about it. So there were issues like I can say that we bullied at workplace and it was like discrimination or discrimination. So again, it's something which I cannot say. So they did not go into work when this person had this particular situation, did not go to work because of the issues, so they avoided. So some of the issues which happen in workplaces are also affecting mental health. Small things like microaggressions, and I think some of you may have these experiences. Microaggression, discrimination, racism. It's not necessarily institutions. It's a subtle thing which happen to people. And these really lead to a lot of confrontation and personal conflict, and therefore raising mental health issues. Again, the stigma is a big issue. So this person says it's really, really big. Stigma is big. Stigma is big. We have lots and lots of examples. For example, this guy I know, he does have a serious problem. It's a mental health problem. With this one, this person used to be really good, but then he has this thing. You see, now they think it's God's punishment. So there's also this belief that mental health is not there. So mental health, if someone has got these issues, then it must be God. So relating this with God punishment, which is significant. So in terms of how people access services, it's also some of the questions which we have to do, because services are there and they're equally available for everybody, but are they accessible to everyone, including multicultural populations? This is another vignette which someone talks about. You know, if you are visiting mental health clinic, if you are visiting mental health clinic here, you are considered as an outcast. It's a taboo to think about mental health illness. You cannot tell us anymore, I'm really sorry, cannot talk about this. So the person just avoids talking because it's a taboo, it's God's punishment, and therefore it cannot be talked about and people will not access services. So to encourage people to see the services and to access services, this other person who I think was a leader says that we have to encourage people, we have to put more resources in these services and to work with many people in order for them to really realize what are the mental health is, because it's very difficult to define mental health. It's not like we are talking about major depression or some of the psychosis. These things are very rare, but some of these behaviors or emotions or something which really make life not healthy, these are some of the things which lead to big issues. And suicide, which is very rampant, particularly in my community, is something which we don't know, but when we see suicide, we get to be very sad. And this is not only in my community, because Minister Lee talked about it very, very eloquently. So talking about the services, we know that services are available, and I could go to services and get services, but these are not really accessible to many of our community members because they are not ready or they do not address some of the equity issues, which I'll talk on the next slide. So mental health services are limited, they are there, but then they are not equitable because some of the cultural perspectives which I've talked about, they impair or they deter people from coming to this. So the service providers themselves, the workforce is not prepared and tailored to address some of major issues. It's not about being available, it's about being accessible. And therefore the mainstream services which are properly available, they are not necessarily appropriate and accessible to many multicultural community members, and therefore there's something to be done in order to have these services accessible. So when we talk about this, again, from my research, These are some of the factors which protect mental health for not only the community which I'm talking about, but for everybody. So the makers and means of having the mental health and addressing these is not necessarily the health issue. So we need to address broader issues such as employment, having safe employed workplaces, having people who have proper housing so that they can really live well and live a health life, having social networks. Remember how I say that people have flew the civilian unrest, or they have left home and they come to this country hoping for opportunities, but they've lost the network, and therefore if you don't help them support and build new networks, this will not help them with mental health issues. We need to facilitate these services or other things. In terms of language, we need to put people who can speak the same language in services so that people can relate with them. And also we need to address some of the equity issues which I mentioned before. So, because I've been given very short time and I would like to talk for an hour or so. So what can we do then? Firstly, we have to recognize that really addressing these issues is not about equality. We know that services are equally available, but they are not accessible. And here I mean that equality is not being the same. So we need to have equity, which is having this fair and seeing what are the needs and having a just service provision. So in this slide at the bottom, that is equality. You see that the people can, there's food at the end of that fence, but these people cannot fit even though it's available for them. So we needed to address this by lifting a little bit and say that it's not equal, but we needed to have it equitably. And in reality, at the top, at the bottom left slide, that's the situation, the moment that we have services, but there are only a few people, the 50% would not come from migration or from cultural background who can access it. And at the top most is the liberation. This is how it happens when we have liberated. And similarly on the right bottom, you see the person with the wheelchair. That person cannot reach the fruit. But if we could give a little bit of slope to that, then this person can access the fruit, and therefore it can be equitable. So in conclusion, what can we do? Again, as I said before, mental health is not only the health issue. It's not only the health issue. It's a situation that everybody needs to know about mental health. It's a commitment where everybody has to be involved. So there has to be collaboration between multiple players. We need to have evidence which will help with the providing evidence for evidence-based practices and policies. We need to work with researchers. We need to work with service providers from the mainstream as well as from the multicultural services. We also need to work with the policymakers. And I'm really happy that the leaders here and the policymakers and the political leaders are with us here so that we can work together to address many issues of mental health in our communities. So we need to support research, and we work very hard at the Flinders and other universities to see that we provide evidence. Some of the big barriers are funding, because we don't have funding, so we tend to do very small research, or we don't do research at all. We teach more than doing research, but we need research in order for us to develop all these. We need to work with communities, because as we saw those vignettes, we cannot really know about this until when we work with communities. The community leaders, particularly the church leaders in our communities, have been very instrumental in helping the community to understand a lot of social issues, and particularly the mental health issues. Because of the cultural perspectives, because of the beliefs and the faith which we have, we don't believe in mental health, and therefore we need to have this understanding and to merge two areas from the Western perspective and our culture to see that we are addressing these issues and provide equitable issues. So when we have worked together, when we have collaborated, when we have provided research evidence, then we can achieve what we know here as equitable access to mental health. So we are not only providing equality, but we are providing and addressing equity, whereby everybody can reach that fruit and eat it. And therefore, in addressing mental health, we need to address inequities which are available in order for us to be able to say that, well, this system is fair, it's just, and it is working. So thank you very much for that, and hope I haven't gone over time a lot.
Thank you, Dr. Moani, for your support. And thank you especially for your presence and showing us all the outcomes of your research. Thank you. I would now like to call on Mr. Rakesh Gupta to please present an engraved pen to Dr. Moani. I would now like to invite our second keynote speaker, Associate Professor Harry Minas. Associate Professor Harry Minas is head of the Global and Cultural Mental Health Unit, University of Melbourne, and editor-in-chief of International Journal of Mental Health Systems. He has worked extensively on post-disaster mental health response, mental health system development, and human rights in Asia, and on mental health of immigrants, refugees, and asylum seekers in Australia. He has served on multiple Commonwealth and state committees and advisory groups, and has been an advisor to ministries of health and social affairs in several countries in the region. He is also a member of the World Health Organization panel of experts on mental health and substance abuse, appointed by the Director General of the World Health Organization. He is development partner and technological advisor of Asian Health Center, a visiting professor of Universitas Gadjah Mada, Yogyakarta, Indonesia, and a distinguished fellow of the Pacific Rim College of Psychiatrists. Please welcome Professor Minas' recorded video.
Good morning. I'd like to start by thanking the Mental Health Foundation of Australia for two things. One is for organising this important meeting and also for taking, over the past several years, I think, an increased interest in the issue of mental health of immigrant and refugee communities in Australia as one of its areas of priority focus. The topic that I want to speak about this morning briefly is the areas in which our current mental health systems are doing not very well in responding to the realities of a multicultural society. We don't need to go through the figures about how many immigrants there are, how many refugees there are, how many communities there are spread across all of Australia, the number of cultures and languages. We are all very familiar with those things. But I think that the mental health system has not done as well as it might in responding effectively to those realities. And what I will be doing this morning is taking a mental health system perspective, that is all of the components that constitute an effective mental health system. And what I would like to suggest to you is that there are deficiencies in pretty much every domain. In leadership and governance, there are very few people of immigrant origin and refugee origin. In leadership and decision-making positions throughout the mental health system, whether it's in policy making, service design, reform of the mental health system. So leadership and governance is a key issue. We have, over the past 30 years or more, a lot of statements in mental health policies saying that cultural issues are very important. But when it comes to implementation of those mental health policies, there is usually no funding, there is no implementation plan for how the policies are going to benefit people of immigrant and refugee origin, how they're going to respond to the challenges of providing mental health services to those communities. So policy implementation is a major problem. There are very few examples where budgets are set aside to be able to actually produce programs and services that are relevant to immigrant and refugee communities. One of the areas in which I think the failures are most significant is in the capabilities of the mental health workforce. There are very few training programs that educate clinicians across all of the necessary disciplines in how to work effectively with immigrant communities, particularly people who come from very different cultural backgrounds, who have a very different experience of mental health and mental illness, sometimes have very negative experiences in their home countries of contact with mental health services, or with refugees and the kinds of traumatic experience that has such a major impact in terms of their mental health. None of our training programs in medicine, in psychiatry, in psychology, in nursing has a significant component of the curriculum focused on these issues. And what that means is that people come out relatively unprepared to work in a culturally diverse society. Safety and human rights is another issue. We know that if people don't speak English, they don't have access to adequate information. This has been brought home very starkly just in the past few months in Victoria during the COVID epidemic, where immigrant communities who are generally of lower socioeconomic status don't have access to adequate information, don't understand very well what are the requirements in terms of COVID restrictions. And we've had multiple outbreaks now in Victoria where I think this has been a significant issue. We also know that there are problems with safety in terms of understanding prescriptions, drug taking, issues around protecting the rights of people if they're in an inpatient unit or in outpatient services. So safety and human rights, there's not enough attention to those issues in relation to immigrant and refugee communities. Again, one of an area of significant problems is the amount of information that we have about mental health and illness in refugee communities and immigrant communities. The research is very limited. In some ways, just as important as the lack of adequate research is the mental health information system. So for instance, in Victoria, we have a very good information system that captures a lot of information about contacts with mental health services. But although data is collected on country of birth, language spoken, and a number of other relevant variables, the health department never analyses these data and never reports in a disaggregated way about what is the experience of contact with mental health services for immigrants and refugees as compared with the overall community. So we have no information about the relative outcomes of contact with services. There have been, as many people will be aware, a range of different efforts over the past 2 or 3 or more decades to do something to improve the situation that I've just outlined. But I think if you look at how much has actually been achieved, how much have state and territory mental health services changed as a result of those efforts, I think it would be fair to say that the change has been minimal. Changes that have been made haven't been sustained. Where there have been demonstrations that programs that are specifically relevant to immigrant and refugee communities are effective, they're not scaled up through the whole of the mental health system to benefit all immigrant and refugee communities. So I think it's time now for us to be thinking about a more sustained and more integrated approach to these mental health system problems. And one way that I would suggest that we should consider pursuing this as a goal is the establishment of an Australian Institute for Migration Mental Health. What would such an institute do? It would tackle each of the areas that I've mentioned where there are deficiencies. For example, a comprehensive research program and advice and support to health departments to improve their mental health information systems, but also to analyse, publish, make available data about how those systems are performing in terms of immigrant and refugee community mental health. The other area where such an institute could have a major impact is in education and training, curriculum development, discussing with professional associations like the College of Psychiatrists, the Psychology Association and so on, what they are doing in terms of accreditation of practitioners who go through their training systems. Have they had sufficient education and training in working in a multicultural society? I think if you look at how well, and I'll use Victoria as an example here, mental health services actually engage with the communities that they serve, I think it's fair to say that their level of engagement with immigrant communities is very poor. The services generally know very little about the immigrant communities and their particular problems and challenges. They don't know very much about those communities and their capabilities. For example, what the immigrant community organisations are capable of doing in contributing to the positive mental health of their populations. And on the other side, I think that immigrant communities, particularly the more recently arrived communities, have very little information about what kinds of services are available to them, how to gain access to those services, and how to contribute what the knowledge that they have about their own community to improve the relevance and cultural appropriateness of the services that are provided. So another area where such an institute can develop, I think, substantial programs is in mental health promotion within immigrant and refugee communities, certainly suicide prevention programs and other illness prevention programs, but promote engagement and participation of immigrant communities in governance arrangements for local services, for example. Another area where such an institute can have a major impact is in contributing to appropriate service design, innovation, and evaluation of services so that there are services that are appropriate for the particular needs and circumstances. And finally, linking all of those areas together, the Institute could have the necessary expertise in policy analysis and policy development and support health departments to develop policies and programs that are appropriate for a diverse society. One of the most important areas is in assisting with implementation. As I said before, there are very often statements of intent in policy documents around the serving a diverse community, but when it comes to implementation, things fail. So I would suggest that it's worth thinking about whether such an institute, if it could be developed, might provide the kind of impetus and the sustained attention that will be required to bring about the kind of mental health system reforms that are needed if our mental health services are going to be appropriate for and effective in terms of the mental health of immigrant and refugee communities. And I would welcome such a discussion about how such an institute could be established, how it might be structured, what kind of programs it might develop, and also how it might be sustainably funded to do this work over the next 10, 20, or 30 years that will be required to actually bring about the scale of change that is needed in our mental health systems so that they're fit for purpose for the society as it actually exists, which means a very diverse society. Thank you very much.
Okay, thank you very much to Professor Harry Minas. He's not here anyway. Now, I would like to welcome Dr. Nancy Wong, Chief Medical Advisor from the Australian Unity, to say a few words as the Mental Health Foundation's major sponsor for National Mental Health Month 2020. Dr. Wang has a broad range of clinical public health research and implementation experience within the health and aged care sector. Dr. Wang's passion is to reduce evidence practice gaps in healthcare delivery with a focus on prevention, early intervention, and integrated care. Dr. Wang is the Chief Medical Advisor for the Independent and Assisted Living Platform of Australian Unity, overseeing the clinical governance of care to deliver outcomes that matter for their customers. Dr. Wang held an appointment as an adjunct professor in the School of Health and Social Development at Deakin University from 2015 to 2019, and was a director of Vincent Care from 2014 to 2019, established to support and advocate on behalf of the most disadvantaged Victorian. Please welcome Dr. Nancy Wang through a video.
I would like to start by acknowledging the traditional owners of the land on which we are meeting. I pay my respects to their elders, past, present, and emerging. I also want to offer my condolences to those who've been affected by or lost loved ones since the beginning of the COVID-19 pandemic. My thoughts and support go out to all those families. I also acknowledge the impacts of COVID-19 on other countries around Australia and the challenges they are facing. I'm Nancy Huang, the Chief Medical Advisor at Australian Unity. I'm also a first-generation immigrant from Taiwan. I came to Australia at the age of 8 with my family. We were one of the first families from Taiwan based on a skills migration program, as my father was an electrical engineer. And my first language is Mandarin Chinese. I want to acknowledge the sponsor, Mental Health Foundation of Australia, and the great work they are doing in the mental health space. This is Australian Unity's second year of involvement with the foundation, and we look forward to tackling some of the most challenging social issues together. Mental Health Month, held in October each year, is a great opportunity for us to raise awareness about mental health and well-being. and promote ideas to improve the daily lives of everyone. I would like to welcome you to the forum and congratulate you on taking this opportunity to promote activities and ideas that will have a positive impact on our community. As you are aware, and fortunately for me, Australia is one of the most culturally diverse nations in the world. The spotlight since COVID-19 has confirmed that we have to prioritise services and programs specifically tailored to meet the mental needs of our culturally and linguistically diverse communities. Organisations such as Mental Health Foundation Australia are doing valuable work to research and advocate for better services for all Australians. There is much work in this area, including better access to evidence-based services for diverse communities and closing the gap between Indigenous and non-Indigenous Australians. As a nation, we need to improve our efforts to address inequalities and barriers for people to access care for mental health. We need to not just close the gap, but exceed the gap for all. In terms of this year and the outbreak of COVID-19, this will likely have long-term and profound impacts on Australia's physical and mental health. This has been a particular challenge for multicultural communities as it shed light on some of the long-standing barriers to care, such as access to useful information, appropriateness of mainstream health services, feelings of isolation, understanding cultural norms, trust, or respect for government advice, experiences of racism or exclusion and stigmatisation of mental illness can all be barriers. Many recent studies already show increasing rates of worry, anxiety, and depression in our community. While government has committed to funding more services in response, we need to be vocal about whether these are meeting the needs of community groups who are less resourceful or literate in English, or have different cultural norms or help-seeking behaviours. So one relevant area that I would like to call out is the nexus between physical and mental health. In Australia, the high community burden of anxiety, depression, suicide, self-harm sits alongside of heart disease, cancer, respiratory disease in prevalence and incidence and burden. Indeed, there is now a lot of research to show that the link between mental and physical health goes both ways. So a person with mental health conditions actually have a shorter lifespan, usually due to a concurrent chronic physical condition that hasn't been well managed. A person with chronic physical conditions, on the other hand, such as heart disease, also have a much greater risk of mental health issues such as depression and anxiety. And added to that, the specific barriers for multicultural and Indigenous communities I mentioned before, it creates this mounting challenge for people to receive the right care when they need it the most. These complex needs of diverse communities, especially with the new pandemic challenges, are some of the mental health issues that the Foundation and Australian Unity are facing into. At Australian Unity, wellbeing is at the heart of everything we do. And we've been providing services for over a decade to help our members better manage their chronic physical conditions. Our focus is increasingly now around how to integrate care for this individual. About 20 years ago, Deakin University, sponsored by Australian Unity, developed a National Australian Unity Wellbeing Index that measures satisfaction with life across a number of areas, including standard of living, health status, achievements, personal relationship, safety, community connection, and future security. This produces a holistic view of Australia's wellbeing. This has provided inputs into our understanding of factors that influence wellbeing and inform planning and policy making for our communities. Additionally, a new mental health program, MindStep, is delivered by Australian Unity. After conducting a global research in 2015, we adapted the UK National Health Service model of low-intensity cognitive behavioural therapy for people with depression or anxiety. This serves to reduce access issues to care by enabling people to recover and stay recovered in the comfort of their own homes. With good recovery rates, MindStep is being adapted to Healing Minds, which was co-designed with and for Indigenous people experiencing depression or anxiety. We also plan to adapt this for culturally and linguistically diverse communities to respond to the growing needs for services that are proven to work. So we have all been touched by mental health concerns in our lives. Mental Health Month is an important opportunity to raise awareness about the impacts of mental health and the range of supports available that can improve someone's sense of well-being. For me, this has been an important driving force professionally, but also personally. Working as a doctor in Australia, I have witnessed some great developments in mental health care over the last 35 years. However, some worrying gaps remain, which I have experienced recently as a daughter. For over 12 months before my father passed away in September of last year, we tried to find culturally appropriate services and care for him after he suffered a stroke and subsequent depression. His English regressed and his pride with it as he struggled to complete simple daily tasks. Ultimately, after 3 false starts, we did find a care team that was able to meet his needs. But there was a heavy toll on my mother and the rest of the family. So I am committed to ensuring that we maintain a focus on innovating and tailoring services and programs that are grounded in evidence and have long-lasting, meaningful impacts on everybody's mental health. For me, this means that sometimes one size will not fit all. And as providers of care, we have to continue to ask the most important questions of what matters to you, rather than just what's the matter with you. We commit at Australian Unity to work with the Mental Health Foundation Australia to identify service gaps. This is an important and exciting partnership that can add value to what we do as individual organisations. And again, I thank the Mental Health Foundation Australia for their unwavering commitment to improving better mental health for all Australians. Thank you very much.
Thank you, Dr. Wang, and to the Australian Unity for their continued support. I would now like to invite Dr. John Brayley, Chief Psychiatrist of South Australia, for his formal address. John has over 30 years' experience in healthcare and has worked in leadership roles in mental health, general health, and disability sectors. Past roles include State Director of Mental Health in South Australia, Public Advocate between 2008 and 2015, and Chief Medical Officer of the Department of Immigration. He has led the statutory appointment of Chief Psychiatrist since May 2018. During this time, the Office of the Chief Psychiatrist has led work responding to the Independent Commissioner Against Corruption's Oakden report and has developed an active program of unannounced inspections of mental health facilities. The office has also worked collaboratively with the Mental Health Commission to develop a mental health services plan for South Australia, which was endorsed by government and released in late 2019. Current projects in the Office of the Chief Psychiatrist include planning and implementing a mental health COVID response, the development of a new urgent mental health center, and designing a suicide reduction for mental health services towards zero. The Chief Psychiatrist's Office has functions in setting standards, monitoring the sector, developing policy and statewide plans, among other roles. Please welcome Dr. John Brayley.
Thank you for the opportunity to speak today. And I think the timing of this presentation in the agenda is good because it's following the scene that has been set from a research perspective from Lillian's presentation, including the problems faced when people seek to access mental health services, and Harry's further expansion on that theme nationally. What I'd like to do is just talk about one part of the potential response that's included in the Mental Health Services Plan, and basically link our statutory role in the Mental Health Act in the Office of the Chief Psychiatrist with our planning role. Because the Mental Health Services Plan talks about the development of inclusion standards. And I think the question is what they might look like, what they might contain, and how they might assist as one part of the response. So in the introduction, you heard about the statutory role, which includes the development of standards, and also the work with the Mental Health Services Plan, which was undertaken with the Mental Health Commission. There is no doubt that there are many examples of good practice, best practice in multicultural mental health out there. The issue is that is not that it doesn't exist. The issue is the variability and the ability to get that wherever a person might present. So you can see examples where services and practitioners have awareness of cultural factors, recognise the impact of racism and discrimination. They demonstrate best practice with cultural inquiry, the engagement of interpreters, and working in partnership with community organisations and non-government organisations that really understand communities. And there are many examples of practitioners and services who appreciate the impact of trauma. And we most commonly see this in the provision of services to refugees and asylum seekers, where PTSD, anxiety and depression, and association with the links to past trauma can occur, and a range of symptoms that can occur in children. So this is out there, but it's the variability. And even as I was coming here today, I was hearing about a situation where a community organisation, or actually a provider organisation with good links to communities, was still having difficulties getting a seat at the table and being listened to and providing information about the sometimes complex situations that need to be considered in delivering responses. So the Mental Health Services Act enables our office to promote continuous improvement, monitor the standard of mental health, and to gazette services and basically set standards. This applies to government health services, private hospitals, and for the state services, the delivery of services to people who are voluntary, as well as people who are receiving involuntary mental health care. Some of the guiding principles of the Act are very significant. I mean, this is the law, this is what we need to be achieving. And the statutory chief psychiatrist role has an independent role to monitor this. But the guiding principles of the Act expect that mental health services should first meet the highest level of quality and safety. And second, be provided, and this is amongst others, be provided in accordance with international treaties and agreements to which Australia is a signatory. This fundamental link between human rights and safe and high quality services. These principles a bit further on go down to say that mental health services should take into account, amongst other factors, the cultural and linguistic backgrounds of persons and the backgrounds, circumstances and particular needs of persons who have experienced torture and trauma. But the question is, what does it mean to take into account? It's defining this that becomes critical. And this is where I suggest that having clear standards of what taking into account, using the highest level of safety and quality can help guide our sector and practitioners. We have the examples of best practice out there. It's using that knowledge, the link with communities and practitioners and experts to develop standards further. Now, the goals of the Mental Health Services Plan, there are 3 broad goals. This applies across age groups, across populations: personalised care, integrated care, and safe and high quality care. I'll just quickly go through each of these goals to look at how it can be relevant to multicultural mental health. So for personalised care, this really came from consumers, carers, the people who are consulted for this plan, and also the state strategic plan that preceded it. People being able to set personal goals, have choice and control, to be able to have greater access to non-drug therapies from our mental health services, a very strong message. And linked with this is the upholding of human rights as an ever-growing theme. It's been there all along in terms of the law and requirements, but something that our sector is wanting to see fully enlivened, and I'm particularly thinking of consumers and carers. So the plan will have a rights analysis on all new initiatives, a strong focus on the use of peer workers, and that would also include cultural peers. There's a specific plan related to older persons' mental health, but as lived experience workers are engaged, the need to engage people from different backgrounds, and inclusion standards. Now, a standard that is developed under the Mental Health Act then becomes binding, and as I say, it can help explain aspects of legislation. But at the bottom, I've just of the slide, I've just put 2 areas where mental health practice brings the assessment to a conclusion. One area on the left is categorisation. So people are diagnosed, they're assigned diagnostic categories. And that requires accurate cultural inquiries, because if it's not a culturally safe approach, the wrong diagnosis, the wrong treatment, whatever it is, the wrong therapy, the wrong medicine could be applied. But on the right-hand side is the need to have individual formulation, basically asking the question about this unique person, this unique individual. Why did this person become unwell in this way at this point of time? And included in that is the cultural formulation. Now, in our role, when we do inspections, we look at case notes, but how in auditing case notes can we identify whether best practice is occurring and whether a person is truly understood as an individual in the context of their culture and experience? There's been a lot written about this idea of individual cultural formulation, and I think whether one follows a practice of doing a formulation or not, the ideas are particularly the components are particularly relevant, because these are the things that we should know about people. So diagnosis is important, but the individual story is fundamental as well. So knowing about the cultural identity of the person, the resources, challenges, predicaments that they might face, and their identification with origin and host cultures. Appreciating cultural conceptualizations of distress, how distress is experienced, understood, communicated. Being aware of psychosocial stresses and cultural features, and the supports that people have available in their communities and environment, and also acknowledging and identifying the cultural features in the relationship between the individual and clinician, the potential differences in culture, language, social status, all of these things that can affect the assessment and the provision of treatment. So this clearly needs contact with the person, the patient, significant others, but also the documentation of this information so that it can be easily accessed. For example, if the person is in crisis and seen by another practitioner. So that's one aspect, the personalised care and diagnosis, but understanding the individual. The second key goal of the Mental Health Services Plan relates to integration. And this is integrating our specialist services with other health, social and community services. One particular example was the accessibility for youth generally, that we need to have common access points for youth, and embedding our specialist staff in other settings that people feel comfortable and safe accessing. So I think with what we've heard today already about the issue of access, there's obvious application. The relationship with community groups, migration and settlement services, non-government services, the links with subspecialist providers, such as STARS that provide expertise and training and advice to other services, and being able to deliver services in locations that are accessible and in a mobile way. The third goal, safe and high quality services. Once again, there's the linking of safety and quality with human rights, and coercion reduction, reducing involuntary care is significant. We know that people from some CALL backgrounds are not presenting early, and when they do present, they are very unwell and therefore more likely to require an involuntary treatment order, whereas early intervention may have led to a different trajectory. So accessible services better uphold human rights, trauma-informed care, and also the work on suicide prevention that focuses on engagement and follow-up. So this is the question of cultural safety, and it's important to emphasise that in using the word safety in this context, safety is the avoidance of harm done by a service on an individual. So by having a culturally safe service, it will prevent harm that may have occurred because a person's cultural background and circumstances haven't been understood, assessed or understood. So in that section, going through those three goals in the plan, personalised care, integrated care, and safe and high quality care. And then the question about standards. I think we do need to acknowledge there's been a lot of good work on framework, guidelines, surface-wide standards, accreditation, etc. But to actually have standards that can be audited against and that actually relate to the individual can provide an extra assurance that the people are receiving care as required. And these standards would need to describe the values, attitudes, knowledge and skills required to provide evidence-based care. But they'd also be looking for evidence that cultural inquiry has occurred and informed the best possible diagnosis and an understanding of the person as an individual. So that's just some background on the this question of standards, and also the question of the mental health services plan and how an inclusion standard could be one component, just one component in addressing the gaps in mental health service provision that currently exist. Thank you very much.
Thank you, Dr. Brayley. And as a small token of our appreciation, you will now be presented an engraved pen by Miss Helena Kriapoulos. Okay, just a little bit of changes. The Bollywood dance will be performed later on during our lunch break. We will go straight to the panel discussion on the theme of better mental health for all and its implications on communities. I invite Ms. Helena to please moderate and facilitate the panel discussion, and invite the following panelists to join us on stage. Dr. John Brayley, Chief Psychiatrist, Professor Nicholas Proctor. Nicholas is the Chair Mental Health Nursing Leader of UniSA's Mental Health and Suicide Prevention Research Group. He is a former member of the writing team for Australia's National Suicide Prevention Strategy, Life Framework, and the steering committee for the Commonwealth Ombudsman's own motion investigation into suicide and self-harm across the Australian Immigration Detention Network. In addition to the many other activities, Professor Proctor is an advisor to Australia's National Suicide Prevention Task Force and Australia's national representative to the International Association for Suicide Prevention. Ms. Inam Udi. Inam has over 35 years of experience working with multicultural communities in Australia and overseas. Her community health nursing career has mainly focused on public health issues, which includes gambling, mental health, blood-borne viruses, family violence, and much more. Currently, she is the manager of the Multicultural Services at Relationship Australia in South Australia. Her restorative practice and leadership qualities have always been influenced by the people whom she works with, especially those with lived experience. Ms. Zakaya Muhammad is the accredited mental health social worker. She is the manager of the Health and Family Safety Program at the Australian Refugee Association, and also has a private practice where she supports females through life course under Medicare who have a mental health care plan, and also those who require non-directive perinatal counseling support. These are our panelists for this afternoon.
Thank you. Look, we're actually running a little bit late if you haven't worked that out at the moment, but it's obviously such an important topic at the moment. And we haven't had a symposium or a conference on mental health and wellbeing for quite a long time. So clearly there is a lot of interest in this space. I've been given some questions that I could ask the panel, but you may have some questions that you might like to ask the panel yourselves. There is a microphone out here at the front if anybody would like to step up. We won't pass the microphone around at the moment, but is there a question from the audience that you would like to ask? Yes, over there. Just come up to the front, please.
My name is Jolly Winter, and I have several hats here for community organizations that I belong to. My query is really regarding continuity of care, because I have a lived experience with a relative who's got bipolar, and I have experienced such a gap in the continuity of care for that particular relative.
Who would like to answer that one? John? You can all have a go, yeah?
Yes. Thank you for raising that question of continuity of care. And this is one of the broad quality areas that need to be improved in the mental health services as they're currently delivered. We do have many instances where the follow-up does occur, but the problem of people not having continuity of care information, it was certainly an issue that came up time and time again as the mental health services plan was being developed, and it will be part of improvement strategies. It's delivered by the need to have good care anyway, but there's just increasing evidence, well, it's been for the last 15, 20 years, but in recent times as well, about the life-saving effects of good continuity of care, how important follow-up is after somebody's been seen in crisis. And initially it was thought it was really important they be followed up in a week, but actually sort of day 2 or day 3, follow up when people leave hospital, and good connections between primary care and specialist services. So the question of continuity of care also applies to all partners. So if there are NGO specialist organisations providing multicultural mental health, or community organisations, that they are connected in, and everyone is fully informed with the information that's required to make that care safe.
Thank you. Anybody else like to? Yes, off you go.
Hi, so I'd like to speak on this on behalf of the Australian Association of Social Workers, where they've really worked in leaps and bounds in regards to putting together packages around getting social workers with their correct skills and experience to be trained to be psychotherapists, and to allow community members to access services around mental health funded under Medicare. So I don't think that's promoted widely enough within community for people to have an idea about that. And especially now that the services are now where people are able to now access 20 appointments instead of 10 under mental health care plans. This can also be delivered by an accredited mental health social worker within community. So I think that has really made a lot of difference in regards to offering community members continuity of care.
Thank you.
I just wanted to say thank you, Charlie, for raising this personal issue. And I'd like to take the opportunity to acknowledge all people in this room and outside this room who have a lived experience, because without them, I don't think any of us could be sitting here and speaking from so-called an expertise. And I am the first person to say I'm not the expert, but I am heavily involved with people with lived experience, including personal one within the family and outside the family, my cousin who committed suicide, and many more. I think integrated care, and I fully support Dr. John. I think this is something that we are working on, and I'm pleased to say that I sit on the advisory committee for the implementation of the service plan, and I make this statement today for everybody. I am not there as an AM. I'm not there as the Peace Multicultural Services or Relationships Australia. I'm here, first of all,
as a migrant community who have grandchildren, children, grandchildren, who are also, some of them are affected by mental health. So I have a personal investment in it. And so if you have any ideas that you'd like me to represent you at the advisory committee that is chaired by John, I would love to hear from you. I am actually your voice. I don't take this position lightly at all. Thank you.
Thank you. Are there any other questions? Please.
Hi, my name is Maria. I'm representing the Spanish community. My question is, often when a GP said, yes, you have to see a psychologist or it will be advisable, I think psychologists tend to be quite easy, in inverted commas, to assess. The problem I get from my community is that when they need psychiatrists, that become a very difficult thing, a very difficult service to access. And I think what we forget is that when we have a pain, but our head is still working, and the doctor said, well, it's not too important, come back tomorrow, that is fine. But when we have the problem in our mental, it's a mental problem, and you do not find the service, you are already lost, because it may take you another month before you gain the clarity in your brain to go and look for that psychiatrist again. I think that referral system for mental illnesses are the same that for physical illnesses. And I think we are losing there a reality that mental illnesses pose a great energy in the person that have that day the clarity. Often, you don't have that clarity that day. You may then say, you know, I'm going to give up and jump out of the bridge. And I think we are missing that difference between physical illnesses and mental illnesses, and how important it is to get that psychiatric service.
So just let me just clarify, is it that you're not able to get access to?
Yeah, some of my communities say that it's very difficult, depending where you live, to get access to that psychiatrist service. The psychologist services tend to be easier, but a lot of them come back to me to say, you know, actually the GP who is looking at a huge amount of people and they only have 10 minutes to talk to you, say, why don't you go and look for the psychiatrist service that is better for you? Excuse me, how do I do that? I have to say that you know, I've been with people and I'm, you know, I speak English and I can articulate my needs, but when I talk about multicultural people who can perhaps not even articulate those needs in English, they don't understand the system and they are in that pit, how they're going to do that?
So,
how we can improve
So there's
that?
actually a couple of issues there. One is access to a clinical psychiatrist, but the other one is a culturally and linguistically relevant psychiatrist as well, because obviously having to use interpreters can hinder a service. So can I pass it over to the panel? Nicholas, do you?
I won't speak specifically about the psychiatrist, but there is something else embedded in your statement, embedded in your question, which I think is incredibly important, and that's about getting the right person for me. Someone who understands me and someone who will give me the best possible care. And often the gateway to the best possible care is that I feel respected, I feel validated, and I was able to tell my story in a safe way. And I think that is one of the most important messages that we need to keep making sure is readily heard by all people of all disciplines. Because if we have the right situation for someone to be able to tell their story in the safe way, it helps us to get to the heart of the matter. And oftentimes people say to me, you know, my first appointment, it's the first time I've had this kind of appointment with a psychiatrist. I need to get my words right. I need to be able to tell my story the right way. It's an appointment that's important to me. So I will hand over to John or to Imam, but I think your statement has so many other qualities that I wanted to draw attention to. So thank you.
Thank you, Nicholas. Maybe it's an opportunity now to say that culturally meaningful service is a matter of expectation. So it's what do we expect to get from the service provider? And when there is a mismatch between the two, there is a lot of disappointment. And we label this as culturally inappropriate. So I think there are two things in here. One is absolutely, like John and everyone else have said this morning, and it was articulated in Lillian's presentation about how people spoke about, for example, being unhappy or unaware of the services, or, you know, we've heard about coming late and all of that. As a service provider, one needs to know, what does happiness mean for that particular individual and unique experience individual? So I'm a Palestinian by origin and I speak Arabic. It doesn't give me the authority to speak with knowledge and expertise about everybody who comes from my community, because my experience is my experience. So that's as a clinician. As communities, we have a huge role to play to help people understand what help looks like. When you seek help, what help looks like, what does human rights service means, and empower them. I think the problem that we face in Australia as migrants and refugees is that we don't advocate for ourselves. We're highly divided, and we need to get together and start really advocating for what is best for us.
Thank you. John, is there anything else that you'd like to add?
Yes, I think this point about the difficulty in getting appointments and those access barriers, which after a person's got to the point of perhaps overcoming their own fears and some stigma about seeing a mental health professional, then not being able to find it, or as Nicholas was suggesting, the importance of, if you've waited for this 50-minute appointment, for it to be totally beneficial and for a connection to occur and for the understanding of culture to be there. These questions about accessing services applied to psychiatry, also other disciplines. There can be an economic issue with the gap payments as well. The College of Psychiatrists for some time has had lists of practitioners who have had other languages that they can assess people in, and currently there's work that's being done between our mental health services and the Adelaide Primary Healthcare Network about integrating approaches, because sometimes people may not get in to see a psychiatrist quickly enough, but there could be another professional that they could be connected to who could provide an assessment and support, even if the psychiatry appointment is still required.
Thank you. Oh, one more question at the back. Oh, I won't need to read any of mine. Anyway. Thank you.
Hello, my name is Estella. I belong to the Spanish-speaking community, most predominantly Latin American. But we work in a project which is more community-focused. So it was really interesting to hear the systems change that's taking place and acknowledging those gaps and barriers, which are very real, as you've all mentioned. I'm really interested in the work that is going to be developed with communities and that developing that community capacity and acknowledging the differences. I always talk about diversity within diversity. I'm also part of the Salisbury Suicide Prevention Network on the steering committee of the CALT, and I'm also part of Leland and a community consultant with Relationships Australia. So I've been doing work and hearing stories from our community for the last 2-3 years, and without realising that I also have lived experience just from that from that work that I've done in paid capacity and not paid capacity. So one of the things that I wanted to mention, acknowledge, was when we talk about leadership, those opportunities for mentoring, when there are grants, those opportunities to consider those projects, initiatives that are not necessarily aligned with peak bodies, and the relationships that can be formed with peak bodies that represent multicultural communities, but also the very much grassroots communities, and those opportunities for community capacity building. That's really important. So I'd like to know how that is going to be included and discussed around systems change, which is really important. And I just wanted to mention how this system creates so much barrier, and I think we all acknowledge that. Thank you.
Inam, Zakira? I just wanted to mention, thank you, Stella. In January, there will be a course, accredited course. It's the first of its kind in South Australia. That I'm offering it free of charge. I'm calling it a foundation course, and it is targeted at anyone from cultural and linguistically diverse background who have a lived experience, who will be given an opportunity to learn as part of Certificate 4 in Mental Health, peer support, because I am a very strong advocate. I know there is a lot of peer support movement happening. Stella mentioned LILAN, which is the Lived Experience Network, but I'm yet to see a movement from multicultural background. And that's why I advocated very hard for Relationships Australia, right from the board down. This course needs to be offered free of charge for people. And it will be available. If you know of anybody who is up to the task, I will be more than happy to hear from them.
Thank you. Zakira?
Hi, I think within the Australian Refugee Association, people assume that we're just a settlement service, but we also have a program that is around family health and wellbeing. And that is really an all-encompassing program to anything to do with family health and wellbeing. So it covers family and domestic violence, parenting, disability. And what we try and do within those programs is really link with and collaborate with other services, larger services such as Anglicare, DHS, FECA, Adelaide Primary Health Network, in regards to offering a more holistic service. So we may not specifically work directly and advertise services around mental health, as we know that this in itself can be a barrier within community around taboos and so on. But we offer a holistic services and then we enable all of our staff, paid and unpaid, to have information around mental health and to be able to identify barriers and behaviors around mental health. So more recently, in regards to the other speakers, we've had 2 recent events. So one was with Mamusu, who's a young African woman who got together 50 women within the African community, all who were young women, for an event over the weekend, talking about mental health and stigmas without any shame and looking at that. And then we also funded, with Constance Jones and the African Women's Federation, a camp at Milo, where there was a group of women who went along to that, who were able to discuss issues around mental health without any taboos, without the shame, looking at services, looking at how to link with community, because the majority of people here are community people. And so it's really about making those links. For me, I think it's a beautiful experience looking out into the audience and being able to see people in paid and unpaid capacity who are really utilizing their time by helping community, getting the word out there in regards to mental health, and really knocking down those barriers and building communities where discussing mental health and how it affects us as individuals without any shame or taboo. And it really is around meeting community members where they are at and offering their services there.
Thank you. Nick?
Just one thing that I often consider is so incredibly important, something to celebrate, is the storytelling that goes with the migrant, refugee, asylum seeker experience. And storytelling is such a profound human capacity. It's what distinguishes us as from all other species on the planet. We can tell stories. And I think one of the greatest stories that's not really well told is how mainstream mental health services can learn from culturally and linguistically diverse communities. They can learn how to survive alone. They can learn how to get through some of the most amazing challenges. And if we can find a way through whatever education is available to be able to share those stories in a safe way, in a way that's on your terms, I think mainstream mental health services could learn a lot from all of the wisdom, the lived experience, the thinking, the problem solving, the sense of family, the sense of community. All of these things can be so powerful. And I would really encourage that in a safe way that's absolutely on your terms.
Thank you. We have one more question. Okay, off you
And you can carry on this conversation during the lunch.
Thank you, Helena. And this question is for John. I'm thinking from the well-being perspectives. I'm a public health physician, and when I think about the multicultural, the mental health is not about individuals, it's about the whole community. And when we define mental health, it's really hard to mention what mental health is, because it's not necessarily the psychotic or major disorders. It is those behaviors and some of the stressors which people have lived. And when we heard some of those voices from people, some people were actually very specific and say, well, you know what, it's not about major illnesses. It's just when you see people are stressed, then they come out as very violent. Do you have seen young people, particularly the African communities, who are very violent, and they have been even mentioned as gangs in the eastern states? In South Australia, it's a bit quiet now, but in the past we have had even people killing each other by knives. And from the guidelines which you have, I think it's really good and comprehensive, but I didn't see it from the framework where it's well-being and having health promotion and community wellness programs which are going. And I hear Zakia talking about, well, these stories which are really beautiful. And I don't know those stories if they were captured in that plan. So my thing is to work as an advocate, devil's advocate, and say, what about your office? Do you have any way of expanding those plans and really having the wellness framework instead of coming from the illness framework? Because what we hear is people who come here, they have care, they have this and they have this, but we haven't seen how do we go to the community. Listen of those stories which Nicholas was talking about is multicultural, because you are very communal. And really, my mental health issues, I'm not going to go to a psychiatrist, because really it's something which is a taboo, something which is, if I talk about it, I'll be seen as crazy. So those are things which really I would like to see whether there are any avenues to look at that from the mental health perspectives of the community.
Thank you.
Yes, thank you very much, Lillian. I think the work today was about services and specialist services, but the importance of highlighting the social determinants, the well-being approach, addressing communities has to be part of a total population health plan. And I think from your public health perspective, you know, clearly the great gains that can be achieved through supporting the mental health of entire communities, providing, because mental health isn't just a health problem, as you clearly illustrated in your presentation. We need to inform that from our office and participate in that. It's also potentially a cultural issue as well, because a lot of the planning for services focuses on individuals rather than groups and communities, and that sort of individual-centric approach is sort of a cultural perspective on healthcare in itself. So we can inform and participate and connect. We have colleagues in the mental health area of Wellbeing SA who join us for all of the key meetings. For example, in planning the COVID-19 response, there's a range of initiatives, some very clinical, but some very community focused, including the services, for example, from Ask Peace. So, but it's a very important message, because addressing people waiting in emergency departments is fundamentally important. We've got to get that right, but we ultimately get that right by looking at the well-being of the entire community, not just the way we provide specialist services to people who are sick at that time.
Yep, thank you for that. And also, Zema, just a quick one.
Hold on, we are so over time, unfortunately. And
Can I just quickly finish? Because that also deals with research, and from that plan, I didn't see much about research, and heard about minister say, well, during the COVID, some of the leftover monies was used for outreach services. And that's really good, because then we have to have COVID for these outreach services to be developed. And I wonder whether there would be any avenue for us to work together to develop those outreach services, including incorporated research avenues so that we can build evidence for you to use in your office for developing these practices, which are quite appropriate then.
I'm sure they are, and part of the integration that's required as well. Thank you.
did you want to say one more thing? And
Thank you, Lena. I just wanted to say that we cannot just rely on the individualized service. We have to do the community, and they go hand in hand. We have at Ask Peace, which is funded by the Chief Secretary Office, we go out to the community, and from there, because we build the trust, not just the information, and we destigmatize the issue, we pick up a number of clients who take us on the side and say, hey, you said this, can I talk to you individually about this? I think it's a starting point, like John said. Today, I feel that the services is much better than 20 years ago when I arrived. It's better than 10 years ago. We're not perfect, but we are moving towards a better one, I think.
so I'm going to close it up, but I think we could have carried on for at least another 45 minutes. There will be many more questions, and I haven't even got to the questions that were given to us via the Zoom chats. So my sincere apologies for that. Please put your hands together and thank the panelists. And
thank you to all of our speakers for such an insightful panel discussion. I know we would need more time. There would be a lot more questions and answers required, but we can do that during lunch break. Now, I'd like to ask Helena back here again on stage to give our panelists our engraved pens. Or you can just go there. Okay. The Mental Health Foundation Australia organizes the annual Australian Young Writers Competition for primary and tertiary school students as a part of the National Mental Health Month Awareness Campaign. Students were encouraged to write a poem, a story, or a play on positive mental health. The competition this year was expanded nationally and received entries from all states and territories in Australia. And I'm extremely proud to announce that we have among the 2 students who have won the competition in South Australia. May I please request Associate Professor Dr. Lillian Mwanri and Dr. John Brayley to come on stage and present the awards to our winners. The winner for the upper primary category is Nawal Ali of Year 6 from the Australian Islamic College of Adelaide. Nawal Ali wrote a piece titled The Rose of Marie. Nawal Ali to come up to receive the award. The prize also include a cash prize of $100. The winner for the lower secondary category is Stevie Flame Turner of Year 7 from the Streaky Bay Area School for his piece titled Roses Are Me, Violets Are You. May I also invite Stevie Turner to come up to the stage to receive his award. Yeah. Okay. Congratulations to our winners, Nawal and Stevie, and thank you to Associate Professor Dr. John Braley. Thank you. We're going fast here, okay? Fast forward. I now invite Dr. Daru, Doctor. I have promoted you. Mr. Daru Kumar, Chair of the Australian Multicultural Ambassador Program here in South Australia, to speak on this successful program by the Mental Health Foundation Australia.
Good afternoon, ladies and gentlemen, our respective guests. I'm Dhruv Kumar, Chair of the Australian Multicultural Ambassador Program for South Australia. The aim of the MHF Multicultural Ambassador Program is to further engage multicultural communities in promoting positive mental health and well-being through a network of dedicated volunteers throughout Australia. We, the ambassadors, connect Mental Health Foundation Australia board and staff with our respective communities and promote MHFA activities as a vehicle for engagement and inclusion. The program provides community leaders like us with an official platform to become involved in the introduction and coordination of mental health related program in our communities, as well as opportunities in professional development. Among our ambassador team Access Australia's, we have professionals, doctors, students, youth leaders, and business people who have demonstrated a commitment to their community and have been selected for the influence, the impact they are having on Australian in their community. The Australian Multicultural Ambassador Program has been successfully running for the last 4 years, with ambassadors setting a high standard for this program. As a chair, I thank you everyone, and I belong to Sandharankari Mission and this community all over the world and here in Australia as well. This community is involved in everywhere like blood donation, food drive, and cleanup drive. So as a chair, I'm feeling very blessed to part of this community and working this Mental Health Foundation Australia. I would proud to call upon my ambassador team from South Australia here on the stage, please. So I will call all the ambassadors and my team on the stage, please. All the ambassadors, please come on the stage. Where is Rakesh? So this team of dedicated volunteers have a passion for change. They would like to create conversation about mental health and have been working tirelessly with their communities and to all the places they go so we together can break the stigma, promote better mental health for all. If you are passionate about mental health, then this platform is for you. I encourage you to join this team of dynamic ambassadors. You can look up for more information on your website, www.mhfa.org.au, or we all will around here. So please feel free to come and have chat with us. Thank you to my Multicultural Ambassador team for the work that you are doing, and together we are proud Australian Multicultural Ambassador team here in South Australia. Thank you very much.
Thank you, Daruv. I would now like to invite Professor Nicholas Proctor for an address. Professor Nicholas Proctor, RN, MBA, PhD, is Chair, Mental Health Nursing, and leader of the Mental Health and Suicide Prevention Research Group, UniSA Clinical and Health Services. He is currently Australia's national representative to the International Association for Suicide Prevention and a member of the expert advisory group to the Office of the Prime Minister's National Suicide Prevention Advisor, National Suicide Prevention Task Force. Please join me in welcoming Professor Nicholas Proctor.
Thank you very much, and thank you very much for the opportunity and the invitation to spend time with you. Now, I think I'm one of the last speakers before lunch. So I'm going to I'm going to take that into conscious play right now and talk to you. And in a sense, when I prepared today's presentation, I had no idea about how some of the discussion would go, but I think it'll go very well, and I think it'll fit very nicely. And I wanted to kind of say that we've been looking at what makes effective engagement possible, particularly around depression and anxiety, for some time. So we've been asking some key questions about what are the attributes, what are the qualities, what are the things that we should take special attention and care about when it comes to engagement with culturally and linguistically diverse communities, particularly around depression and anxiety. And we've started to look at that. So much of what I'll draw from today in today's presentation comes from some of that work, plus some more recent work, which is not going to be discussed today. But in particular, a series of studies that have asked questions, for example, of immigrant new mothers. So I'm going to draw out 4 studies, if you like, and talk to you about not just the study, but about the attributes of the study which made it effective. And this is sort of something to think about when you're perhaps giving advice about research or giving advice about clinical services or advocating or leading in the way that you do. So the first one is the experience of new mothers and symptoms of depression. So this is about engagement with new mothers in Australia who scored on a clinical significant way in a depression scale. The second study is about Chinese Australians who were introduced to some internet support. Okay, so some support that meant that they could get treatment through an app on their phone or by going to the internet for support for treatment and depression. The third one is about understanding the experience of depression for people of ethnic communities living in the community. So not people in hospital, but in the community settings. And this was an analysis of in-depth interviews about that treatment. So this is, again, this is an Australian study. And the fourth one involves people from low-income communities and who participated in some focus groups about treatment for depression, again, in the community. So I'm just going to draw out 4 studies and have a look at what made it effective for people not only to participate, but to benefit from the therapies and the treatments that are not necessarily about medicines, but about talking, conversation, and cultural understanding. What these programs had in common was that there was a lot of front-end work even before the program began about engagement. And if we think about much of the conversation today, it's been about culturally appropriate, culturally acceptable forms of engagement. And that meant a conscious effort to set the scene, an understanding and a validating of cultural values and preferences. So even before the study began, there were some deep conversations, respectful conversations, and deeply engaging conversations with community and community leaders, people who could understand the perspectives of people running programs, undertaking research to evaluate the programs, but also carefully considered part of the therapeutic process. So it wasn't just about the design of the program itself, but the processes inherent in the conversations and the talking about the care and the treatment that was made available. and engagement through the use of technology and other mediums that was considered to be acceptable to community members. So yes, you have computers and you have apps on the phone. How can we make things different so that community members are going to find what is embedded in the app, the messaging, the way it's pitched, the colours, the framing is acceptable to community members? And there were no forced choices in all of this. So this is not about research on you, this is about research with you, with community, and that's a standout quality in these successful programs. Consultation and discussion on appropriate engagement and participation, and right through to appropriate channels to promote the services. Ensuring a culturally appropriate meals, refreshments and venue was made available. So where would you like to meet? What would you like to eat? What would you like to drink? What would be an appropriate and a timely place for us to come together? And ensuring that out-of-pocket expenses were covered. So these studies that are successful, that are welcomed within communities, take these into considerations into account. And in some cases, covering the cost of childcare and respite care if required. So particularly for older participants who may have caregiving responsibilities, ensuring and monitoring safe transport options to and from venues. That was made available as well. This point about validating and accepting and respecting cultural values and preferences in treatment and support is also a major standout in successful work in this area. So the next three slides summarise those key points. So taking account of any specific cultural practices, developing the content, for example, in a depression prevention program for low-income Latina mothers, researchers recognise the importance of family and Latino culture. So the conversations were family included types of conversations. Similarly, the family relationships and integrating cultural values in this particular study around Latino culture. So a lot of time was spent establishing this kind of attention to personal dimensions of a relationship and the talking through and the understanding of that so that it was part not only of the research process, but part of the treatment and therapy engagement process. Family orientation was targeted through the incorporation of family-based activities. So the researchers, as well as people providing therapy and support, were very conscious of that. And finally, the content, when we look at the integrated cognitive program, was modified to better reflect Chinese values and realities through methods that were right for the group. So this is a good example here just from this particular study around Chinese Australian depression, cultural values and respect and interpersonal harmony, redrawing illustrations to reflect people with Asian features, for example. So I move away from a Western way of imposing thinking or imagery. Considering gender preferences and spiritual or religious practices important when planning and implementing successful programs. So I guess all of this thinking has come through. And 3 slides about language considerations. So what are the features of a successful project, successful engagement around mainstream mental health services and COLD communities when it comes to language? Well, various language considerations were commonly described in these successful studies, including the use of multilingual facilitators or therapists for assessment, intervention, or research activities, translated assessment measures and intervention written materials being available in the community's language or language of choice, and consideration towards appropriate terminology and culturally appropriate or consonant language. So, for example, with a group of Chinese Australians, there was some rethinking about the term sadness to a new term which was acceptable to the group around brightening your mood program as being appropriate. Other phrases and concepts were adopted instead of depression and included low mood. So it's being open to this, being able to look beyond taken for granted assumptions and having, if you like, you bring a wide-angle lens to these questions, which is so important to be open to new possibilities and fresh ways of thinking. And then around logistics, making sure that in all of these programs, carefully considered, discussed and considered aspects of logistics. I've touched on some of that for childcare, but it's certainly addressing transport concerns and issues early on and in a safe and flexible manner throughout the project. So this is what the standouts were for successful projects. So what's all this about? It's the coming together of many things. Doing things with community, not to community, challenging visible orthodoxies and monocultural ways of working from within a mental health service or from within a framework of thinking about how to evaluate a mental health program. But importantly, and I think this goes to a comment I made earlier, it's about ensuring that people from community are our teachers. They can help us to look beyond taken for granted assumptions. So we have to be open to strength-based co-design across all phases of projects. So projects and initiatives from conceptualization, design, logistics, engagement, and of course, sharing the benefits. What I didn't see in these studies was co-authorship of publications. And I think that is a really important, again, a really important way of sharing the benefits. And co-authorship doesn't necessarily mean writing out things in publications or reports. That could be through oral communication and being open to that. So here's the point: bring a wide open lens to what you're doing, validate concerns and needs early on, be transparent. These are the qualities, these are the features of, if you like, bridging these gaps, creating trusting connections, simultaneously making it clear how these efforts are designed to help and support community. So a very straightforward analysis of a lot of different papers and studies that have happened, and particularly in the last 15 years. From a larger study, I've just pulled out 4 and shared with you effectively what those attributes are. So thank you very much for your attention, everyone.
Thank you, Professor Proctor, for sharing an informative presentation to us this afternoon. Now I'd like to move on. I'm pleased to welcome my fellow Australian Multicultural Ambassador and Social Media Coordinator, MCA Committee, and the recipient of the Mental Health Youth of the Year 2020 Award, Mr. Watnak Bai, to share his story and achievement with us.
Ninamani. First of all, I would like to acknowledge that the land I'm standing here on today is the traditional land of Ghana people, and I pay my respect to the connection, to all the connection to the land. A quick update from a social media perspective. At the moment, we have reached a large amount of audience watching us live nationally on all our social media. My name is Watnak, 2020 National Mental Health Youth of the Year, 2018 Young Citizen of the Year. The list can go on, but you can call me as someone who has been diagnosed with a serious mental, what the professional said, illness. Before I continue further, I need to give a disclaimer. The story you're about to hear may be confronting and disturbing. Sometimes words can cause sadness and distress or trigger traumatic memory for some people. For some people, the responses can be overwhelming. And if you need to talk to someone, support is available here at the Convention Center, or you need to call to the Suicide and Crisis Support Team Lifeline on 13 11 14, or our Mental Health Foundation Australia helpline on 1300 643 287. As Associate Professor Lillian has said, in Australia, 6 times higher rate of psychological distress for young men than young women. I was born in Phnom Penh, the capital city of Cambodia. A single child was born in a very unfortunate family. When I told people I was a single child of the family, the response I got from them, "Oh, you must be spoiled." In fact, it was not. My mother left my father when I was 5 years old to live at the other side of the globe. Growing up in Cambodia without a mother was extremely difficult. I wish I could do a piggyback on my father's shoulder alongside my mom walking on the beach, but that was just a dream. For my whole kindergarten, primary, and high school life, I was bullied from friend, schoolmate, neighbor. They were including guns pointing toward my head, waking up at 3 or 4 a.m., walking around the block, picking up any bottle or can, selling, hope to get 5 cents or 8 cents to cover one meal a day. After my father and my mother officially divorced, Dad was the only one in the family earning. So we calculate the salary in Cambodia by month. So monthly, he would get $30 to $40. That was 30 days of work from 7 a.m. to 5 p.m., Monday to Saturday. As a male-headed household, you are not supposed to be weak. These were the concepts, the belief that made my father into a deep depression. I know he was abnormal from the inside, but the outside, he was always and continued to be a strong person for this son. 2 or 3 times a week, he went to the only nationwide mental illness hospital in Cambodia to get the tablet, which cost 80% to 90% of his salary per month. Every day in Cambodia, more than 4,000 people were admitted to the mental health hospital in Cambodia. I was not too sure until today, and I still did not know how to cope with all this pressure. I continued my education, my belief that if I want to break the cycle of poverty, I need to educate myself to get more knowledge and understanding. Dad met my stepmoms, and stepmom sponsored us here to Australia. Life in Australia was not that easy. I started school at Adelaide Secondary School of English here in Adelaide with no word of English at all. During the time, I found my other half. You can call it the first love. After 4.5 years, we broke up because of reason which I could not accept it. This have triggered my emotion and my memory. I did not want or never want to talk about breakup, a similar term to me as a divorce, because mom and dad, they divorced. The first night, I was in a really dark cloud. My body felt numb. I felt pain in my chest. It was difficult to breathe. I was thinking to use all my savings, disappear myself from South Australia, to move to the other state, change my name, and start from zero. I was thinking of driving my car, hitting the tree or any spotlight. Every night, I was self-harming myself. My body felt numb, no pain, no feelings, and I attempted suicide 2 times by jumping off the jetty. But it was saved by the public. No one would notice this behavior at all. In the morning, you can see me smile and laugh, talk to people, but at night, this darkness and thoughts continue to haunt me. One night, around 2 to 3 o'clock in the morning, I went downstairs, threw the scarf over the garage roof and about to hang myself. Just about time I'm pulling the scarf over my neck, the consciousness hit me back again. I swear, I did not know what's happening this time. The only person that have noticed it, to me, she's my older sister, my friend, my goddess that saved me, Mimona, my team leader at Peace Multicultural Services. She asked me, and I quote, and I remember this quote, "I have noticed you were not yourself. What is happening?" That is the only sentence that I wanted to hear, that no one have asked me that before. During this time, I got full support from my workplace, and then the trust and the leadership of my practice manager in MOD, which is something that I could not thank them enough. Many people use the word "Watnek committed suicide," but I did not. I attempted suicide. The word play an important role, as we have discussed in the early. I then talked to my GP about the helps that I could get. I lost myself in the mental health care plan. We call it the yellow paper. A system that I was told the counselor was not my option at all. I have to refer myself, GP have to refer myself to see a psychologist. The result, I was diagnosed with bipolar. Then the psychologist referred me upward to see a psychiatrist. And the result, I was diagnosed with borderline personality disorder, or BPD. So who am I then? A bipolar or a borderline personality disorder? Medicare back then helped me with appointment to see GP and psychologist, but for my psychiatrist, my GP referred me to the private one. The reason, due to the high demand in public hospital, the waiting time period back then was unknown. I went to borrow some money from a private loan to pay the upfront payment, which I need to work over 2 weeks just to pay off the amount which I borrowed from the lender. After the appointment with the psychiatrist said to me, I do have a group therapy, Swatnek, but it is very expensive and I don't think you can afford it. I was speechless. So that's the helps that I got from the psychiatrist. I was talking to a Medicare professional and none of my cultural perspective were taken into the account. I realized for me, the only time that I could break this help is to go back to study. And over time, I'm questioning myself, so who am I really, bipolar or BPD? But then these two diagnoses have made me unique to be a person who I am today. The label did not stop me there, but the label is helped me to help more people in the sector of mental health. This lived experience person have completed a degree, a 2-degree Bachelor of International Development and Social Sciences at the University of Adelaide, and completing my diploma of counseling. And now I'm working as a counselor and case manager with ASPIS, a services by Relationship Australia. A newly services that support people go through the impact, those who have been impacted by COVID-19. I was fortunate enough to know the services and to navigate myself around the services in South Australia. But what about my family member, my friend, newly arrival, and my fellow co-community member? What about my friend, my international student friend? How do they navigate the services? Each day, ASPI's phone keep ringing, and that have shown that the mental health support is needed. Myself, my family, my community member across South Australia in need of a specific co-design program like ASPI's. My work did not stop me just there, and I have applied and selected to be one of the multicultural ambassador with the Mental Health Foundation of Australia. MHFA is an organization made up of people of walk of life that include professional, a person with lived experience like myself with mental health, family of those living with mental illness, related organization concerned with mental health, and member of the public with an interest of mental health. Mental Health Foundation Australia is the oldest foundation association in Australia, founded in 1930. This work has continued me and allowed me to continue my education. And last week, I got a scholarship to continue my education forward in Master of Counselling, specialized in advanced practice at the University of Southern Queensland. Mental health does not discriminate culture. And being a student studying anthropology throughout my whole course, appropriate and sensitive mental health intervention for whole community are very important, and especially towards suicide. Did you know suicide accounts for more deaths of young Australians more than car accident? Currently, I am also volunteering my time designing a mental health project called Untangle, the first mental health lived experience services back in Cambodia, funded by the United Nations Development Program, UNDP, part of my international development. So when we always talks about mental health month, it is an important reminder for each and everyone in the community here to pay attention to raising awareness about mental health. And myself, I'm a proud saying that I'm living with experience, and this experience makes me unique to help other people in the society. We are here advocating for mental health, educate ourselves about mental health, promoting mental health and well-being in our community. So hashtag mental health matter. Thank you.
Thank you, Watnak. We're so proud of your achievements and your scholarship, and we love you, okay? Now we would like to, I'd like to invite Helena back on stage so we can present certificate of appreciations to our performers today. And I'd like to request when your name is called, if you can line up here so we can have one picture. We'll do it on stage this time, okay? I'd like to call on Ria Montiel-Diorisio. She is the chairperson of the Samahan Group. Sorry, getting confused. Of the Sampaguita Filipino Cultural Entertainers Incorporated. Ria is the president. Sonia Odquin. Vilasminda Bascom. Clarita Lucentes Nosdo. Monique Uribe. Josefina Brasig-Girdle. Los Pori Shields. Lucita Montiel-Diorisio. Maria Villanueva. I'm getting you to exercise. Happy with that. Edwina Peter Hansel. Teresita Forrester. Rose Priest. And I intentionally put the men last. Lito Odquin. And Jeff Nichols. Is Jeff around? Jeff Nichols. Where's Jeff? Hey? No, Jeff? Jeff. Come on this way. Jeff, you stand this, so both men are at the end. Ladies and gentlemen, this is the Sampaguita Filipino Cultural Entertainers. And you can watch them while, before you have your lunch. They will be performing for us, so stay and watch. And they're available for any invitations, okay? Promotion. Anyway, thank you. Now I would like to invite Daruv again, Dr. Daruv Kumar, to give us the vote of thanks for today's event.
What a day has it been. Very pleased to be standing here among us these dignitaries and witness them render their addresses. Australia and multiculturalism never apart. This symposium is very timely and very appropriate. Mental health of the multicultural communities are very unique yet diverse. I would like to thank all those who have gathered here today because each one of you participation sends across a strong message that multicultural mental health matters. On behalf of the Mental Health Foundation Australia and the Australian Multicultural Ambassador Program here in South Australia, I have the pleasure to thank all the guests very much for their active participation and commitment to create conversation about multicultural mental health. My sincere gratitude to all the speakers today, Lord Mayor of City of Adelaide, Sandy Shore, the Honorable Stephen Wade, MLC Minister for Health, the Honorable Jing Lee, Assistant Minister to the Premier. Also, I would like to thank Mr. Picton, MP Shadow Minister for Health and Wellbeing. Our keynote speakers for the day, Associate Professor Lillian Mamwari, Professor Harry Minas, Dr. John Burley, and Professor Nicholas Protector. I would also thank to Dr. Nancy Hong and my dear fellow ambassador, Mr. Wonthok, for your very insightful and informative message and addresses. Thank you for panel members, Ms. Inam, Jaika Muhammad, for their time today. Ms. Aida, thank you for your brilliant, encouraging MC today. I would also thank you to our director, Helena, chairperson, Vasan Srinivasan, all board members for their commitments towards better mental health. A special mentor to our staff, Priyanka, who worked behind the scenes in making this event happen. I thought my dream would be multicultural society, one that is diverse and where every man, woman, and child treated equally. I dreamed of a world where all people of all races work together in harmony. Nelson Mandela. I look forward to your support towards the foundation and our future endeavors. See you all in the next year. Please enjoy the live performance now from Ria and team while enjoy refreshment. Thank you very much.
Thank you, Daru. Now, lunch is available outside, and we would like to request everybody if you can just get your packed lunch and come back to the room, and you can watch, eat. You can even dance if you like. Okay, so you can join them. So for the moment, go get your lunch outside, and please do come back. We don't want you to go away, okay? Can we invite everybody to come inside the hall, please? Those people from outside, if you've got your food, can you please come inside so we can start the entertainment for you? And you can move forward because some of the guests have left already, so you can move forward and be closer to the stage. What now? Can you invite everybody to come inside, please? They can bring their food and drinks. Okay, there are plenty of seats in front if you'd like to move forward. The entertainment is about to start. No, you can eat while you watch, but you cannot eat while you dance. They can eat after. No, they're very versatile. Okay, let's give them a big applause. Yay! Come on. Put your food down. You can have food on one hand and clap with your other hand, either on your cheek, anywhere. Clap with the other hand. Okay, ladies and gentlemen, the Sampaguita Filipino Cultural Entertainment Group.